We are ready to go, Doctor.
The first slide. First slide. Put the brochure slide.
I think Vernon, once you start, everybody should be muted except for the speaker.
So can we start, Abhishek?
Yes, sir.
Yeah. Good morning, dear friends.
Yeah, we can start.
Good morning, dear friends, and welcome to this morning session of the Think Active series, which has been started last. I think we have had already 2 series of these, and we have got a good response, especially the exam students. And I welcome all the students, especially the other participants who are viewing this webinar. And this webinar has been organized by the Department of Neurosurgery along with the Midwest chapter of Neurological Surgeons. That is the Maharashtra chapter also. It is known as the Maharashtra chapter. And we have 2 presidents of the MCNS here, Dr. Dev Pujari, who is the outgoing president, and Dr. Keki Turel, who is the incoming president. He's the president for this year. And I welcome all of you all, especially the moderators as well as the speakers. And I'd like to thank Baxter for supporting us in this program. It takes a lot of organization, Baxter and the team. And Ajay Bijani, who is the head of operations of Baxter, has been very kind and helpful in organizing and coordinating this program. So Ajay, without wasting time, I would like to for you to take the stage and our moderators for the day.
Thank you, Dr. Velho. It's been kind of you to kind of us to show our collaboration and partner with this academy activity, and we are more than willing even in the future to partner these academy activities. So I've been given the privilege and the honor to introduce the moderators. So we have Dr. Chandrasekhar Dev Pujari with us. Dr. Dev Pujari is the professor and head of neurosurgery, Bombay Hospital and Medical Research Center, Mumbai. Dr. Dev Pujari has over 25 years of experience in neurosurgery after his training in Newcastle upon Tyne, UK, and Detroit, USA. He is the chairman of WFNS Neuroendoscopy and Neuroendocrine Committee. He is the director of neurosurgery services at CMAST and the founder of the Neuroendoscopy Society of India. Dr. Dev Pujari has a keen interest in endoscopic and minimally invasive skull-based neurosurgery and has authored 3 books, 12 chapters in books of neurosurgery, and over 65 publications in journals. Welcome, Dr. Dev Pujari. We also have Dr. Keki E. Turel. He is a professor, honorary professor, consultant neurosurgery, Bombay Hospital Institute of Medical Sciences from 1988 onwards. He was the chairman of the department for almost 16 years, from 1994 to 2010. He is now emeritus professor at the same institution. He is a pioneer of microneurosurgery in India. He described original X-ray science and designed various surgical instruments. He has been the member of over 30 national and international societies. He is the past president of 3 international and 2 national societies. He is the founder chairman of International Conference on Complications in Neurosurgery, ICCN, from 2017 onwards. He has an honored inclusion in more than a dozen prestigious national and international biographics and has received 18 national and international awards. Welcome, Dr. Turel. We also have Dr. Matthew Abraham. Dr. Matthew Abraham is the professor and head Department of Neurosurgery, Sri Chitra Tirunal Institute of Medical Sciences and Technology, Thiruvananthapuram, Kerala. His field of interest are vascular surgery, including surgery for intracranial aneurysm, AVMs, vascular anastomosis, epilepsy surgeries, surgeries for skull-based tumors, eloquent areas and insular lesion surgeries, thalamic and intraventricular tumors and lesions, and pineal lesions, pituitary tumors. He has got more than 50 publications in peer-reviewed journals in the specialty. He has been an examiner for MCS neurosurgery and DNB neurosurgery in multiple centers across the country. We also have Dr. Deepak Kumar Gupta. He's a professor and consultant neurosurgeon, Department of Neurosurgery, All India Institute of Medical Sciences, Delhi, and associated Jayaprakash Narayan Apex Trauma Center and adjunct faculty of IIT Delhi. His areas of interest is pediatric neurosurgery, congenital spinal tumors, craniovertebral junctional anomalies, minimally invasive spine endoscopic surgeries, brain trauma, peripheral nerve and brachial plexus surgeries, neuro-oncosurgery, neuro-oncology and skull-based tumor, biomedical testing of spinal implants, and study of brain injury models with FEMs. His key achievements are he actually conducted first successful craniopagus separation surgery on Odisha twins. We all know about that, who were totally fused at head and were considered inseparables. This work was widely appreciated by neurosurgeons and neuroscientists all over the world. He has also received appreciation from President of India, Honorable Shri Pranab Mukherjee, on 14th of June 2017 for his work on brain tumor awareness drive. He has got more than 150 international and 50 national publications to his credit. Welcome, Dr. Gupta. We also have Dr. Suresh Sankla. He is the head Department of Surgery, Global Hospital, Mumbai, India. He is the current president of Neuroendoscopic Society for the period 2019 to 2021. He is the past president of Indian Society of Pediatric Neurosurgery, Indian Society of Neuro-Oncology, Skull-Based Surgery Society of India, and Bombay Neurosciences Association. Welcome, Dr. Sankla. And we have Dr. Ketan Desai, who is the senior consultant neurosurgeon, PD Hinduja Hospital and Medical Research Center, Mumbai. With his 25 years of experience in neurosurgery, Dr. Ketan Desai has performed almost 3,000 surgeries in brain and brain and spine segment. He's been trained and experienced in various subspecialties of neurosurgery, including vascular and skull-based, neuro-oncology, spinal surgery, and pediatric neurosurgery. Dr. Desai has completed advanced fellowship in various aspects of neurosurgery in New Orleans, Munich, and Marseille in France. Since 2001, Dr. Ketan Desai has taken a special interest in brachial plexus peripheral nerve surgeries. He has already performed more than 600 surgeries of brachial plexus injury and has handled almost 110 cases of brachial plexus tumors. And in addition to that, he has done almost like 350 operations related to other problems, including peripheral nerves. So would like to kind of welcome again on the behalf of the entire group of Baxter as well as the participants to all these moderators. With this, I will kind of give it back to the moderators to take the session forward. Thank you. Sir, you are on mute.
Yeah, thank you, Ajay, for that introduction. And now I'd like to invite Dr. Ketan Desai to introduce the first speaker.
Dr. Desai, you're on mute. Can you hear me?
Yes.
Yeah. Thank you, Vernon and MCNS for giving me this opportunity. Thank you, Baxter, for organizing this webinar. I'm sure it would be very helpful. Our first speaker is Dr. Sukhdeep Jawar, and he is a senior consultant neurosurgeon at Sadhguru Pratap Singh Apollo Hospital in Ludhiana. And Sukhdeep, as we all know, has got a phenomenal work in the anatomical dissection of brain and its structures. And we have been witnessing his work for last 5 years. And during this lockdown period, we have heard him talk on posterior foci anatomy, brainstem, cerebral vasculature. And as a part of the further extension of his talk, today we are going to hear him talk on endoscopic anatomy of sella, cavernous sinus, and internal carotid artery. Without wasting much time, I invite Dr. Sukhdeep. Sukhdeep, please.
Thank you, Dr. Ketan Desai. I hope everyone can hear me. A very good morning to all the esteemed moderators, panelists, and attendees. And a special thanks to Dr. Vernon Velho and Baxter team for giving me this opportunity. So today, my topic of discussion is endoscopic anatomy of sella and cavernous sinus and internal carotid artery. So all these dissections, most of them were done at the KEM hospital, and some endoscopic work was done at the UPMC. So all the works is done by me. So you can see the brain here, and you can see how beautifully the brain is having this anatomy here. This is the lateral view, the hidden view. The skull base is hidden below this brain here. So the secret is to unlock that anatomy. For a young neurosurgeon, when we are trained, we are mostly trained in the microscopic this microscopic neurosurgery, we have orientation of the brain from superior aspect, from lateral aspect. But when we start seeing these endoscopic surgeries and we start seeing this endoscopic pituitary surgery, the anatomy, and I must say the perspective changes. The anatomy is the same. So you see the skull base here, you can see all the cranial nerves here, you can see here optic nerves here, and the optic chiasma, and below there is some pituitary stalk area. So the change in the perspective due to this distortion, or you can say optical distortion of the endoscope. Sometimes it can be very confusing. So when I started, like I was trained at KEM, we were doing pituitary surgery microscopically, but when you see the anatomy from endoscopic perspective, you get confused. Where is this structure? What is this structure? Why we are seeing so much? So the thing is, in the microscope we have a flat picture, which is kind of 2D, but our brain gives us 3D information. But this endoscope give you this parabola, like a curved kind of picture. So even your view increases too much. So that view can be confusing. But if you know the anatomy, if you know their this dissection, then you can be very comfortable, and it's a very rewarding branch to learn. So what I realized is I attended few workshops here and there, but then in the workshops time is very limited. Specimens are sometimes not that so good, and somewhere you feel you are not learning the proper technique of this proper anatomy. So I went to UPMC. I spent some time and did lot of dissection on this endoscopic route, and then you get this hands-on dissection. Keep on doing, then you get the real feel of the anatomy, and you know how these things are related to each other. And another thing is, when you are doing hands-on, it makes your reflexes very fast, how to handle these cameras, how to handle these instruments. So the endoscopic may look very nice and very beautiful, but we have to understand that we are operating from the distance between your target and your hands is very long. So even a small movement can get exaggerated. So you should be very careful with these instruments, careful with the anatomy. So here is the sella area. Here you can see this the optic chiasma. You can see pituitary stalk, and of course these are peduncles and brainstem here. So this is just to show some anatomy of the lateral nasal wall, because for endoscopic approaches you have to be familiar with nasal anatomy. As neurosurgeon, we are very confused. Where is this turbinates are coming? Where these conchas are there? Then there are other things, the very vascular area of this nose. So once we know some nasal anatomy, so then we will be more comfortable in these approaches. Otherwise, you have option of having a ENT colleague who can help you, but still you should be aware of this anatomy, how to reach the sella, how to reach the sphenoid sinus, how to move these structures in the nose. So this is the mid-sagittal section. Now you can see here is the sella, how it is related to the nose. You can see almost all of the skull base can be reached through transnasal route. This is the anterior skull base. You can see here the cribriform area and almost the frontal lobe, basal frontal lobe here. Then this is the middle cranial fossa. You can reach from here, and the sella here. This is a stalk here. This is the sphenoid sinus. And if you see the clival area, this gives you access to even the pons and the posterior fossa. So once you know this relation and you know how to reach which area, it is very easy very easy to reach these areas. So this is the inferior turbinate, medial turbinate, and middle turbinate is one of the most prominent structure which you will be encountering when reaching the sphenoid from here. So once you lateralize the medial turbinate, then you see the superior turbinate, and just close to the superior turbinate is your os of the sphenoid sinus. So this is again a visual orientation from a line diagram. So you can see how this carotid artery is entering the skull base, then it takes a turn in this in your petrous bone, then it enters the cavernous sinus, and finally it reaches the intracranial compartment. So I'm just showing you these diagrams. Then we will be visiting again through the dissection how these things are related to each other. So you can see the GSPN here, greater superficial petrosal nerve branch of facial nerve, and it is joined by this deep petrosal nerve. in the pterygoid canal, so forming the Vedian nerve here. So Vedian nerve is also called nerve to pterygoid canal. So through this pterygoid canal, this joint here, sphenopalatine ganglion, then you can see sphenopalatine ganglion is attached to the V2 here, and from V2 and sphenopalatine ganglion, you have branches to the oropharynx, nasopharynx, and part of the buccal cavity. So Vedian nerve is kind of a landmark for our approaches to the skull base. If you are planning some extended skull base approaches, you can see how it is related to the foramen lacerum here, how it is related to the carotid artery. So it gives you that orientation, and because it can be easily accessed through nose, so once you reach, it's a good, useful landmark. So that's why I'm showing here Vedian nerve here. So traditionally, carotid artery has been divided into various segments from proximal to distal, or sometimes from distal to proximal. So many students, they find it very confusing to remember C1 segment, C2 segment. Of course, one or two classification you can remember, but many times, even during our residency or after that, we found it very confusing to remember. And in endoscope also, sometimes it's when you see the carotid artery, it is difficult to ascertain which part of the carotid is there. So there is a different, more useful, and I will say more practical kind of classification for carotid through endoscope. So segments are divided according to their relation to the anatomy. If it is related to the clivus, it is paraclival. It is related to the sella, it is paracellar. So related to clinoid, it's paraclinoid. So it's easier to remember. I will say more practical, more useful kind of classification. So we will be coming to that. So first we start with the bony anatomy. We all know this is this is the frontal view here. This is the sphenoid bone. But many times we forget this bone. This is the ethmoid bone. So ethmoid is a very, you can say, very cancellous kind of bone with lot of hair cells, lot of complex this anatomy. So when we are going through the nose, many times this ethmoid is related to the face of your sphenoid. So sometimes you have to take out these posterior ethmoid cell to gain a wider access to your sphenoid sinus and to your skull base. So we must remember this bone. So this is how it is related. Now you can see from side on, this is all ethmoid. It's a very big bone, very rarely, given importance, but you can see how it is related to the sphenoid here. So this is the optic canal here. We have the superior orbital fissure, and between this, the bone is optic strut. Just remember the words which I'm saying. We will be coming back through endoscopic point of view. So optic strut is basically the bone between optic canal, which is, you can say, second nerve, and superior orbital fissure. So this is the partition. This is optic strut. If you go down, we have our V2 here and the pterygoid canal here. So this is the frontal view. Now with orientation, now you can see how big is this ethmoid bone here. This is the nerve to pterygoid canal. This is the foramen rotundum here, and we have pterygoid plates here. So this is just the frontal orientation of your. Now we have taken out the ethmoid. You can see how this big is the now sphenoid sinus here. So sphenoid sinus can have various type of septa, and in preoperative scans you should study these septa and see if you can during your surgery you try to get, they are your basically landmarks and give you orientation to the carotid and other vital structures. So this is the top view of the sphenoid bone. We have anterior clinoid here. We have the sellar cavity. So sellar cavity is bounded interiorly by these two, you can say, tubercles. So this is tuberculum here, and on posterior is your dorsum sella. So remember this anatomy here. These are the tuberculum. Many times people get confused. Where is tuberculum? Where is it? And you see some elevation here. This is basically middle clinoid process. So this is tuberculum sella, middle clinoid process, and this on that top is your, this is the limbus here. So on front of the limbus is your planum sphenoid. So planum sphenoid, then there is the limbus, then basically this is the part where you will find your falciform ligament, optic chiasma will, this will come here, and this is their tuberculum sella. And this is, and one more structure which you see here is this prominence here. So this is your this is I'll come back to that. So this is your view from the posterior. This is the dorsum sella. You have superior orbital fissure, and we have the foramen rotundum here, and this is the optic chiasma. This is the chiasmatic sulcus here. So this is how the skull base is oriented. We have our occipital bone. This is the clival part of the occipital bone. This is the petrosal part of the temporal bone. This is again the sphenoid bone. And these three bones, they kind of form a synchondrosis. This is not exactly you can say fissure. So the synchondrosis, this creates an opening here, which is our foramen lacerum. So not a true kind of foramen, but this is a junction of these three bones. So this is now I'll just show you some microscopic pictures, then we will be seeing them endoscopically. This is how the cervical part of internal carotid is entering here in the carotid canal and going to the petrous part. So this is the cervical part of the carotid artery here. So this again, this is the petrous part. You know how all this petrous ICA has been dissected here. Of course, this is the facial canal here and the facial nerve going and branching here. This is the external carotid artery, and this is your mastoid, which has been drilled. So we have a cervical part, then the petrous part here, and from petrous part, it's entering here the cavernous cavernous sinus. Once it enters, it's from laterally it is covered here. You can see by the fifth nerve here, and these are the injection of cavernous sinus. So then it goes, here is the supracavernous part. So this is once it comes intracranially, then it, of course, we have the beautiful view of the ICA here. This ICA is dividing into two ICA bifurcation. This is the anterior cerebral, this is the ACOM, and this is your optic chiasma here. So this is again the view of the ICA bifurcation and some branches to the basal ganglia. So this is all here you can see beautifully how the skull base has been dissected, just to show some cavernous sinus here. This is the fifth nerve branching into Meckel's cave, and then V1, V2, V3, and this is all the seventh nerve here, then going along here, it's coming out through the stylomastoid foramen. So coming back to the cavernous sinus, this is the view of cavernous sinus from the microscopic perspective. I'm just revising it fast so that you get orientation when you will see through the endoscope. So this is the fifth nerve here. This is the third nerve. This is the tentorial edge. And you can see this is the clinoid process. This is your optic nerve. This is ICA. And this part which is behind the clinoid is the paraclinoid ICA. So once you lift this, then remove this venous injection. We have retracted the third nerve. Then you can see sixth nerve going inside the sinus here. And sorry, this is the fourth nerve. This is the sixth nerve here. And sixth nerve coming below this ligament. Which is this ligament? This is Gruber's ligament or petrosphenoid ligament. So this is the ligament through which it enters here, and then it travels along here to the cavernous sinus. So this is again the view. Here you can see ICA in the petrous bone. Then so petrous ICA, then it enters here into the cavernous sinus, and then here it takes a bend, and it is giving branches to the lateral cavernous wall, and you can see third nerve retracted. So now we have removed the clinoid process also. So here once you remove the clinoid, this is your proximal ring, and this is the distal ring, and between these two we have our paraclinoid segment of the ICA. This is again supraclinoid ICA. Many during junior neurosurgeon, they get confused what are these rings and all. Now you can see how beautifully these rings are there. So it is basically an extension of dura. One goes above the this clinoid process, one goes below the clinoid process, just forming these two rings around the ICA or the carotid collar. So fifth nerve, third nerve, fourth nerve, sixth nerve, again this Gruber's ligament. So this is all after the dissection. Now you can see all these triangles here. We will not go into the detail. So this is the top view of the sella here. Of course, this is again the meningohypophyseal branch here. This is again the Gruber ligament, and this is your sixth nerve, Dorello's canal. So coming to the This is the how you will see your sphenoid sinus once you open. You can the septa can have various configuration. It can be the midline. It can go to one side of ICA, and there can be multiple septa. So the idea is to study this septa in preoperative CT or MRI, whatever you have, and see where they are leading you. And during surgery, they give you good orientation that you are not deviating from your midline or deviating from, because in the endoscope you will get a very panoramic view of your sella cavity. In microscopic sometimes we just get this much view, but here you are seeing all the bends of ICA. You can see optico carotid recess here. So we have to be careful with our anatomy. So coming to a stepwise approach to the sella, you can see here we have just showed the sphenoid ostium just close to the midline. So various landmarks are there. You can just retract middle turbinate. You can see the superior turbinate, and medial to it you will mostly find the sphenoid ostia, or you can see the from the here opening in the oropharynx go 2 inch above that, and there can be the opening of this thing. So this is the opening of sphenoid ostia on both the sides. So once you see how this is the keel of Vollmer is oriented to the sphenoid sinus, very important landmark for the midline. So here you can see both sides sphenoid ostia. Here this is the anterior skull base. This is your middle turbinate. So it's a big turbinate. It gives you that access to your posterior ethmoids, and it also gives you access to the sphenoid sinus. Of course, these are here ethmoids have been removed. Just this is the posterior ethmoidal artery. So you can cut it during dissection, or in some approaches, if you need a wider access, you can cut it or you can lateralize it. Here we have cut this middle turbinate, and then you can see some bulk.
Sukhdeep, sorry to interrupt you. Can you move your cursor slowly so that people can understand what you are showing? Thanks.
Okay, sir. Can they see my cursor? Okay.
No, it's not very clearly seen.
Okay. So I think this is some problem with Mac, but I will.
No, it's okay.
Yeah. So once we cut the middle turbinate, then we have this. We have this sharp edge-like structure, which is uncinate process, and this is bulla. Bulla is ethmoid bulla. So these are mostly nasal anatomy, but we need to know this anatomy so we can get oriented. So then we remove the anterior wall of the sphenoid sinus. So we are still not in the sphenoid sinus, we in the nasal cavity. So once you remove the anterior wall of the sphenoid sinus, of course that will give you access to the sphenoid sinus. And sphenoid sinus is your, you can say, working area, your access to all of the middle and anterior skull base. So it is very important that your sphenoid sinus is well aerated, well pneumatized. If it is not very well pneumatized, of course, that is a relative kind of contraindication to these approaches. So you can see how this sphenoid sinus is aerated. This is a very big sphenoid sinus, and you have a very nice midline septa here. As you know, midline septas are not that common, but sometimes you can find these even in these cadavers. So this is the midline. This is the view which you will get once you enter your sphenoid sinus. Of course, you can remove the mucosa. So this is a very wide access. You can see here, I can see the anterior skull base, which I showed you. This is the plenum area. Then I showed you some that chiasmatic sulcus. This is that chiasmatic sulcus area. This I showed you some tubercular area. These are your tubercles here, and you have your ICA impression very beautifully. This bone can be very thin, sometimes even absent in old age, and you have to be careful. So you can clearly see pulsation in some of these sphenoid sinuses. So this is your impression of the ICA. This is a cellar part of the ICA, and on top of that, this is the impression of your optic nerve. And so between optic and carotid is your opticocarotid recess. Very important landmark. Very commonly people say LOCR, MOCR. So you just have to remember this is your lateral opticocarotid recess. So this again is the impression of the optic strut, which I showed you. What I showed you is the optic strut is the bone between optic nerve and superior orbital fissure. So here you can see this is the bone, this is that impression. This is the ventral impression of the optic strut. So the very commonly asked question is which is the ventral impression of the optic strut. So ventral impression is the lateral opticocarotid recess. So I will be repeating these anatomical landmarks so that you get a good memory for this. So it is very important, these landmarks, and landmarks are your key to your endoscopic surgeries. So optic nerve, superior orbital fissure, lateral opticocarotid recess, which is a ventral representation of optic strut. So coming back to the sella, so this is the bulge which you will see. This is your, of course, the sella. This is your cavity for the pituitary gland. Of course, when you see have tumors here, this will be quite big. It will all be bulging into the sphenoid sinus. And of course, once this below this bulge, you will have this ventral impression here, a kind of cavity which is your clival recess. So this is the clivus, this is the sella, this is the planum. So in short, this is a good view. So this is just a close-up view of that. So before going further into sella and into the intracranial part of the endoscopic anatomy, we must remember these approaches. They have a very high risk of your CSF leak, and when you are going through nose to the cavity which is sterile, where there is no infection in the brain, so any cavity we are creating is a source of infection, and especially in our setup with sometimes patients don't follow up properly, so we have to be very careful about the CSF leak. So any CSF leak can be devastating for a beginner, for a new endoscopic surgeon. It can be very discouraging. You may start thinking, why I am doing this surgery, why I am doing through nose, why can't I go from brain? So the key for success is to have a very robust, this kind of flap is there, which is a Haddad flap, also called nasoseptal flap. So these flaps have totally revolutionized this endoscopic skull base surgery. Previously, the leak rates were around 10-15%. Now they have come down to even 1.3-1.5%. So the key is to have a very good, these are all vascularized flap, these are live flap, they have these vessels here, they have this pedicle here. So while you are opening your sphenoid sinus, while you are getting your access to the sella, so you have to be careful with this vasculature. These are the branches of sphenopalatine arteries. We have sphenopalatine, this is the choana here, this is the midline, just to orient. So we have there these descending palatine artery, then we have sphenopalatine arteries. This is a sphenoid sinus. So when you are opening the anterior wall, just be careful on the inferior part. Don't go too much below, and otherwise you will damage these vessels. You may damage the vasculature to this flap. So try to preserve it. You have to anticipate in advance what kind of tumor you are dealing. Is this tumor is going too much suprasellar? Will there be any leak? So if you are, it is always better to have to preserve this pedicle. Sometime a rescue flap you can take in the initially, or you can take beforehand this nasoseptal flap or Haddad flap. So this is the branch here. You can see beautifully how it is going. Usually there are multiple branches, 2, 3. So even if you can damage one, still you can preserve this flap. So try to preserve and see. This is this is in the cadaver also we are able to preserve. So with the live, it will be easy. So once you know the anatomy, once you know this is the sphenopalatine artery, these are branches. So this is all the flap. You can see how big this flap. I can cover the whole, almost all of the anterior skull base with this flap. So this is just to show this anatomy here. We have the sphenopalatine artery, which is branch of internal maxillary, again branch of external carotid. So these are descending palatine.
Can you make your pointer a little bit bigger? We can't see anything here.
So this is the problem with actually keynote. So
Okay.
so it will. Last time also I had problem. So this is the size which stay. So can you see now? So this is your sphenopalatine artery here, and now you can see here. So these are multiple branches. One is going, you can see directly downwards. I'll try to explain without pointing. So one is going directly downward, which is descending palatine artery, which goes to your palate. So one is going directly horizontal, which is the main sphenopalatine artery. You can see here. So these arteries and these flaps are very important. So try to learn how to raise the flap. Maybe in beginning you may not be able to raise a very big flap, but for a sella and a typical pituitary case, a small flap will do your job. But if you are doing extended approaches, then of course with experience you will be able to raise a very big flap and very nice flap. So these are the, again, different arteries and all branches of sphenopalatine. This is posterior pharyngeal artery. This goes to pharynx. Not very important for this, but the horizontal one is important. So coming back to the sella, So this is the view of your sella after your once you remove the mucosa. Now the bone is there. So once you remove the bone, this is the view you get. Then you see the dura. So dura, as you know, is 2 layers of dura are there, and between the 2 layers you have these very large venous sinuses are there. So this is the view with the after removal of the bone. So this is the sella here, and on both the sides you can see the carotid, C-shaped carotid. This C-shaped curvature can be of various configuration.
We have lost him.
Yeah. Ganesh?
Yes, sir. Abhishek here. I think Dr. Sudeep's connection is lost. So I think he might be trying to join back. We'll connect with him sometime. If you or the moderator, sir, can you sort of elaborate further on this topic, and yeah, we can continue, I guess. Yeah.
Chetan, if you can just take over and...
Yeah, I think it was... yeah, tell me. Yeah, I think this presentation is excellent. Only hitch is that the structure which he's showing, we can't view, by the pointer what he's trying to show. So he says that there is some problem in his keynote. So I think whatever he's showing is, is excellent, but unfortunately, it's a bit too fast to grasp it without the pointer.
Ketan, I wonder if you can change the pointer to a slightly bigger size pointer.
Yeah, that is what I told him, but he says that in his keynote, he's not doing on the laptop, he's doing on, I think, the iPad type of keynote.
iPad, yeah.
So that is why he's unable to do it.
Ketan, before we can start with Sukhdeep again, I just want to welcome Professor Atul Goel, who is attending the webinar. We are trying to keep the panelists. I don't know whether bring it in the panelist group. So I don't know whether Ganesh and Abhishek have managed to do it. Welcome, Professor Goel, for this webinar. And thank you for supporting us and supporting the young teachers. And we'll have you on the panelist group soon. So...
we still are trying, sir. Abhishek here. We still are trying to get Dr. Goel on call. We are working in the background. Hopefully we shall have him.
Yes,
thank you, Vernon.
Yeah,
Vernon, can you hear me?
Yeah, we can hear you, Professor Goel.
Yeah, I'm enjoying beautiful presentation. You see, I have a feeling this kind of anatomical work is, absolutely nobody in India at least has done this kind of work. And maybe not only in India, in the world, nobody has done this work. I think we should be very proud of this work that Sukhdeep has shown. There is no question about that.
Yes. Hello.
Well, he's finding some problem. Should we wait or shift to the...
Get back later on.
Yeah, I think we can request the second speaker.
What has happened, Ketan, he has lost power there. There's power cut there. So what we'll do, we'll move to the next moderator. Can I invite Professor Dev Pujari to please come in? Professor Dev Pujari, please.
Dr. Vernon.
हाँ इधर ही देते तो बेस्ट रहेगा फिर मैं अपना ना चेहरा भी दिखा दूंगा नहीं इसमें क्या है इसमें बैकग्राउंड
Can we have Professor Dev Pujari?
दूसरा कुछ इन्होंने लगाया
Can you hear me?
Mute the others, please.
अच्छा मेरा बैकग्राउंड में लेते हैं मैं
Yes, sir, we can hear you. We can hear you, sir.
हाँ
Okay, mute other panelists, please.
To listen to our young teachers, and we also have something to learn from them, as well as a lot of young participants have joined, and it's my pleasure to introduce my colleague Dr. Chandan Mohanty at Bombay Hospital as well as at Madia Hospital. And he is going to talk to us about pathophysiology and management of cervical degenerative disease. He joined us about 5 years ago after completion of his training earlier at JJ, then at NIMHANS, and then in Toronto and Calgary. So look forward to your talk on pathophysiology and management of cervical degenerative disease, Chandan.
Thank you, sir. So, can you hear me?
Yes.
I would like to thank Dr. Vello and the entire Baxter team for this opportunity, and Dr. Dev Pujari for this kind introduction. I'll be talking about the pathophysiology and management of cervical degenerative disease, which has undergone quite some changes in the last few years, in the last decade at least. So we know that cervical spondylosis is basically a specific term for osteoarthritis of the spine, which includes spontaneous degeneration of either the disc or the facet joint. Majority of the times, it is an asymptomatic process, and it causes symptoms in only 10 to 15% of patients. Most commonly seen age group is 40 to 60, and by the time the person is 70, at least 70% of the asymptomatic people will have some amount of degenerative changes in the cervical spine. So we have actually very poor epidemiological data regarding the true incidence of cervical degeneration in general and cervical spondylotic myelopathy in particular. There are some small studies with a relatively small sample size which have shown a point prevalence of 3.5 per thousand population and annual incidence of 83 for 100,000 population. So cervical spondylotic myelopathy, you should all remember, is the most common cause of non-traumatic spinal cord dysfunction and the most common cause of spinal cord dysfunction in an elderly. More commonly seen in males, more commonly seen in Asians than in Caucasians. And cervical spondylotic myelopathy related spinal cord injuries are seen in 4 to 6 persons per 1,000 population, per 100,000 population. So currently our understanding and the change in nomenclature has been to call all the degenerative processes of the cervical spine causing myelopathy as degenerative cervical myelopathy. We currently do not classify them separately into, say, OPLL or cervical spondylotic myelopathy or ossified ligamentum flavum or calcified ligamentum flavum. The reason why this encompassing term was used was it was thought that the degenerative cervical myelopathy has the same endpoint of cord compression and loss of neurological function, irrespective of the initial etiology. So it was easier to combine them into a single overarching umbrella and then to analyze over a period of time. So this is quite a recent development which has happened in the last 5 years. So we know how, what are the zones of potential compression. You can have compression from the disc, you can have osteoarthritis of the oncovertebral joint or the uncinate process, facetal hypertrophy of the ligamentum flavum, or even ossification of the ligamentum flavum. All the pathophysiology of cervical spondylosis begins with the first step, which is loss of water, protein, and mucopolysaccharides, which end up causing a disc desiccation. Following which, there's a fibrosis of nucleus pulposus with fissures and tears in the annulus, which cause loss of disc height and loss of cervical lordosis. And this progressively leads to progressive kyphosis, which in turn causes vascular and neural compression. So it consists of mechanical factors which are both static and dynamic factors progress over a period of time. Static factors can compress vascular structures causing ischemia and apoptosis, and they can also directly compress the neural structures leading to myelopathy and radiculopathy. So this is the pathophysiology of the degenerative cervical myelopathy, which is basically a chronic spinal cord compression which leads to hypoxia, ischemia, cascade, causing apoptosis and endothelial cell dysfunction with neuroinflammation and disruption of the blood spinal cord barrier, leading to neurological sequelae. And these are all the radiological changes which are encompassed in the term degenerative cervical myelopathy. So this is just an animal experiment in which they used fowl, which is a type of a poultry animal. So in the poultry animal, they exposed the spinal cord and they progressively caused kyphosis of the spine, and they inserted pressure transducers into the spinal cord. So when they noticed that initially when the kyphosis is about 20 degrees, there is no significant change in the spinal intramedullary pressure. But once the kyphosis increases to more than 21 degrees, as you can see, there is significant increase in the intramedullary pressure. So beyond 20 degrees of kyphosis in the animal model, what we are seeing is there is a rapid decompensation and increase in the spinal intramedullary pressure. So there is a very wide range of lordosis to some amount of kyphosis, which can be tolerated normally in a human being as well. So this is the same experiment in which they performed a microangiogram in the control group, and there was poor capillary filling when the spinal cord was in a kyphotic position. And this is the histopathological study of the same experiment, where they noted that there is significant neuronal loss as well as demyelination with gliosis whenever we are dealing with the kyphotic model. So smoking, obesity, genetic factors, advanced age, occupational hazards, previous injuries, congenital stenosis, Down syndrome, Klippel-Feil, and spinal deformities like kyphosis or scoliosis are some of the predisposing factors for cervical degeneration. Natural history of degenerative cervical myelopathy, we know that from long-term data that 20 to 62% of mild degenerative cervical myelopathy will progress in the 3 to 6 years period. So there is a certain fragment of a certain proportion of patients who would not progress in at least in the early phase of the disease. Deterioration is noted in 56% of patients for performing their activities of daily living, and there is disease stabilization seen in certain component as well as period of exacerbations seen in another component of patients. So this is a very basic, I think knowing the dermatomal map of the body is extremely important for localizing the disease process, especially of the upper limb when we are dealing with cervical spondylotic myelopathy. We know the C5 is located at the outer aspect of the arm, near the outer aspect of the arm. C6 is usually the thumb. C7 is the middle fingertip. C8 is the little finger. T1 is the medial aspect of the forearm, and T2 is the medial aspect of the upper arm. So there are basically three clinical syndromes of cervical degeneration. The first is an axial neck pain. So this axial neck pain is secondary to cervical disc disease, facet joint arthropathy, mainly in the trapezius, sometimes maybe also seen in, after a previous injury. It is basically accumulation of adenine monophosphate, creatinine, and decreased ATP in these muscles. These causes decreased blood flow in the muscles, and there is also a component of direct irritation of the nociceptive nerve endings in the facets and in the disc. And these are the locations, axial pain patterns which were provoked during discography. This is a classical 1990s study following which we could localize the exact site of pathology based on the distribution of pain. The second clinical syndrome of cervical degeneration is cervical radiculopathy. Now, cervical radiculopathy following the disc degeneration, what is labeled as the recurrent meningeal nerve here is also called as the sinovertebral nerve, is the nerve which gets irritated following a disc herniation, causing the radicular pain. As we can see, the dorsal root ganglia is in close approximation with the disc, and a lateral disc herniation can cause compression of the dorsal ganglia. Excuse me. Cervical radiculopathy is mainly in the C5 and C7 distribution, And spurling maneuver, which is basically extension of the neck followed by lateral rotation, is a provocative maneuver which can elicit pain in the distribution, uh, of the nerve. It is based cervical radiculopathy is basically due to increased substance P in the dorsal root ganglion and the nerve. Mechanical deformation of the dorsal root ganglion causes ischemia of the neurons, and local inflammation, especially high tumor necrosis factor alpha, is also known to be responsible for cervical radiculopathy. The third clinical syndrome of cervical degeneration is the myelopathy or the degenerative cervical myelopathy. And this pictographic representation shows all the changes which are possible in a patient of myelopathy. This can include a loss of vertebral height, disc degeneration, disc herniation, hypertrophy of the ligamentum flavum, uh, early listhesis, presence of kyphosis, etc. So degenerative cervical myelopathy has the following features: usually neck pain, shoulder pain, radicular pain in the arms, unsteady gait, clumsiness or weakness of the hands, stiffness and weakness in the legs due to corticospinal tract involvement, numbness and paresthesias in the upper extremity, and a UMN type of bladder. On signs, we see hyperreflexia in the lower extremities and the hyporeflexia in the distribution of the affected radicle. We see the Hoffman sign positive, which is basically equivalent of a UMN sign like a plantar response in the legs. We have similarly have the Hoffman response for the upper limb. We also see the limit phenomena, which is electric shock-like sensation on neck section, which shows involvement of irritation of the posterior columns and impaired tandem gait. So there are numerous scoring scales for degenerative cervical myelopathy. The most popular of them is the Nurix grade and the MJOA score. The other ones like SF36, the neck disability index, the 30-meter walk test are also being increasingly used. But MJOA, I would say, is the workhorse for degenerative cervical myelopathy. The Nurix grade, as we know, is graded from 0 to 5, 0 being signs and symptoms of root involvement without evidence of myelopathy, whereas grade 5 is basically a chair-bound or a bedridden patient. As we can see, the problem with Nurix grade is it is not taking into consideration the involvement of the upper limb or the bowel bladder or sensory involvement. This was fulfilled by the MJOA score. This is the modified MJOA score. The original MJOA score, the original JOA score was mainly for a Japanese population which used chopsticks instead of spoons. Here, the motor dysfunction of the upper limb is rated from 0 to 5. Motor dysfunction of lower limbs is of 0 to 7. Sensory dysfunction of upper extremities from 0 to 3, and sphincter from 0 to 3. So total score of 18, and out of which mild is 15 to 17, moderate is 12 to 14, severe is less than 12. Some new classification have said a very severe group should also be considered, which is 8 or less than 8 MJOA score. Investigations, I mean, the first investigation usually is an X-ray, and it is limited to a patient with a preceding spinal trauma and advanced degenerative spinal disease. We can definitely see the OPLL, osteophytes, etc. in the X-ray. Dynamic X-rays are extremely useful to demonstrate an unstable segment in the spine. I will discuss about the K line in a second. Also, calculation of all the deformity parameters like T1 slope, C27 sagittal vertical axis, the Cobb angle is all done on an X-ray. So the K line was originally described as a line which is drawn from the midpoint of the C2 spinal canal to the midpoint of the C7 spinal canal on an erect X-ray. If the posterior border of the spine crossed this line, then it meant that the patient needed to undergo an anterior approach. That means the spine was kyphotic and the anterior approach was preferred. If the posterior border of the vertebral bodies were anterior to this line, then the spine was considered to be lordotic enough to perform a posterior procedure like a laminoplasty. This has recently been modified slightly, and this modified K line is the same K line, but it is measured on the MRI. And on the MRI, what is important is that the posterior end of the OPLL or the posterior end of the vertebral bodies should be at least 4 millimeters anterior to this line. If it's 4 millimeters anterior to this line, then a posterior approach can be done. If it's less than 4 millimeters, then anterior approach has to be done and has a better surgical outcome. CT is useful for surgical planning and patients where a traumatic etiology is suspected, and also in patients in whom MRI is contraindicated. So the types of OPLL, this is the Hirabayashi classification, are the continuous OPLL, where you have OPLL extending to multiple segments of the spine. The segmental OPLL, restricted to a single vertebral body. The circumscribed OPLL, which joins two consecutive vertebral bodies, and the mixed type, which is a combination of all these three. Out of all these types, the continuous type is supposed to have a very high osteogenic potential and hence has a much higher rate of progression than compared to the other types. This is the famous double layer sign which is seen on the CT. As you can see, there are two layers of ossifications which are seen behind the vertebral body. The translucent line, which is marked with the white arrow that you see here, is basically the dura, and the calcification that you see after the translucent line is basically the calcification on the dura. So these patients will be at a very high risk to develop a CSF leak or a dural tear, since there is infiltration or adherence of the OPLL to the dura. MRI is extremely useful, as we all know, shows the site and the extent of compression. MRI is also useful to determine the etiology of the compression. So we have the dynamic flexion, extension MRIs, or even the X-rays to detect hypermobility and instability of the segments. Presence of hyperintensity within the cord, that's the myelomalacia changes, are considered to be a poor prognostic marker in neurological outcome. And so the T2 hyperintense signal does not have that much of a prognostic value, but the T1 hypointensity has significant prognostic value in determining the overall outcome after surgery, because that's supposed to be a true indicator of myelomalacia. So one of the very recent advances in spine imaging is the use of DTI and DTI in spine. So so in the first image on the left hand side of your screen, you can see that the T2 weighted image shows some hyperintense changes in the cord, whereas the DTI shows distortion of the blue column, which is basically the long tracts. So once you see this loss of blue color, this is usually a poor prognostic factor for surgery. Whereas on the image on the right side, you can see that the blue column or the long tracts are maintained. You can see the continuity of the long tracts on the DTI. Lowever, if you see an fractional anisotropy value or the ADC value which is extremely low, then it would also again indicate a poor prognostic indicator, irrespective of the blue column being seen or not seen. Now this is still a learning process, since the cutoff values for the fractional anisotropy and ADC are not yet well defined for each spinal segment in different groups of patients, different ethnicity, different geographical locations, age, sex, etc. Electrophysiology also is extremely useful, especially EMG and MCV, especially when there is a coexisting neuropathy or a myopathy. Anterior horn cell disease or Hirayama disease in the early stages can also mimic a cervical spondylotic myelopathy or degenerative cervical myelopathy, and hence EMG and MCP is important. SCP tests the integrity of the posterior columns and can also have a very good localizing value. So Coming to the management. So the candidates for non-operative management are mild and non-progressive myelopathy, that is MGOA 15 to 17, pain not affecting the quality of life, asymptomatic patients with radiological cord compression, patients with severe medical comorbidities. I think this is some of the expert guidelines as to who the candidates for non-operative management are. So non-operative management includes use of non-steroidal anti-inflammatory drugs, pregabalin, steroids, use of cervical orthosis, intermittent bed rest, combination of epidural steroids, nerve blocks, facet blocks. Extremely important is to avoid high-risk activities or occupation when non-operative management is concerned, especially in people who are into active contact sports. Use of traction has also been shown to be useful, especially in radiculopathy, not so much in the axial neck pain. Acupuncture, physiotherapy also have their role in both axial neck pain as well as in radicular symptoms. So radiculopathy, as far as the treatment is concerned, anterior cervical discectomy and anterior cervical discectomy and fusion. The anterior cervical discectomy and fusion results are slightly better than the anterior cervical discectomy alone. Good to excellent results are seen in more than 90% of patients, and the recurrent surgery rates are slightly more with anterior cervical discectomy alone. However, the rate of pseudoarthrosis or non-union are more in ACDF patients, which is about 2.6%. Cervical arthroplasty has been a very interesting topic and a topic of intense debate. Since the medium-term data has been shown to have better results than ACDF across multiple meta-analysis and systemic reviews. However, the long-term data is still awaited. Posterior laminoforaminotomy remains the most cost-effective method. However, the reoperation rates are slightly higher, about 9%. And in many cases, when you deal with calcified disc or spondylotic bars near the uncinate process, it is difficult to release or achieve a good decompression from a posterior laminoforaminotomy approach alone. For soft discs, it is an extremely useful and a simple method to achieve pain relief from radicular symptoms. MIS data, unfortunately, long-term data is still unavailable. So just a few examples, as you can see, regular C6-7 disc with more of a central disc herniation. Once you confirm that there is no instability, can be easily treated with an ACDF. Multi-level anterior cervical discectomies can also be performed with a plate. However, plates currently are slowly going out of favor, and we tend to use more of these standalone cages with in situ screws because the dissection in the prevertebral space is minimized with these implants. This is a patient who underwent endoscopic laminoforaminotomy, and you can see that once you drill the laminar facet junction adequately, you should not be drilling more than 50% of the facet joint laterally. That is the key landmark. And once you drill out the lamina and the foramen, what you usually see is that the nerve root is lifted upwards, and the disc is located on the caudal end of the is located on the caudal end. And once you complete your discectomy, the root kind of falls down, and you can have a good fragmentectomy procedure from a posterior approach. This is an arthroplasty patient, and you can see that the cervical range of motion following an arthroplasty is more or less preserved, or maybe slightly enhanced after arthroplasty procedure. And it is basically very similar to a ACDF procedure. However, the disc preparation needs to be more thorough to accommodate the implants, and the implants then with the ball and the socket pattern, they allow adequate range of motion. Interestingly, the problem with this cervical artificial disc replacement is that most of the patients, in at least 50 to 60% of patients, they end up having heterotopic calcifications. And medium-term data to long-term data does not show preservation of motion as the time progresses. So this procedure ends up being kind of an ACDF as the time progresses over a period of time. So what are the indications of surgery? For degenerative cervical myelopathy, I think the progressive neurological deficits, intractable pain, failure of non-operative management, presence of spinal instability or spinal deformity affecting quality of life are important indications of surgery. Principles of surgery are relatively simple and straightforward: decompression of the compressed cord and roots, stabilization of the spinal column, and restoration of the normal alignment of the spine. Surgical prognostic factors have been studied in detail. The baseline neurological status, that is the MGOA score, is the most important surgical prognostic factor. The poorer your MGOA score, the poorer is the rate of recovery. Hence, the advocates of aggressive surgical treatment do not want the deterioration or progression of the disease, and they are more aggressive with mild cervical spondylotic myelopathy patients as well. Age, we know age of more than 60 years is considered to be a poorer prognostic factor. Duration of symptoms. So a meta-analysis showed that when the duration of symptoms is less than 12 months, whereas duration of symptoms is more than 12 months, there is a 4.8 time probability that the amount of improvement in a patient with duration of symptoms being less than 12 months is going to be 4.8 times better than a patient with duration of symptoms being more than 12 months. Smokers usually have a poor outcome following surgery. Physical and psychological comorbidities have also been shown to weigh in on surgical prognosis. T1 hypointensity, combination of T1, T2 weighted signal changes, and greater levels of T2 signal hypointensities are also shown to be poor prognostic indicators. Low ADC and low fractional anisotropy, as I showed in the previous images, along with disruption of the long tracts in DTI, are also poor prognostic indicators. Correction of kyphosis and sagittal alignment, malalignment are important, since correction of these two parameters cause an improvement in the surgical outcome. As far as surgical techniques is concerned, anterior and posterior procedures are generally considered to be equivalent. However, we ought to remember that there are so many variations in the anterior, so many variations in the posterior procedure, that it is truly very difficult to really compare the variations of surgical technique. But generally, laminoplasty is considered to be equivalent to a laminectomy and a fusion procedure. However, there is some data, albeit a weak to moderate data, which shows that ACDF probably has a better outcome compared to corpectomy. However, it might just be the fact that the patients who end up needing corpectomy may have more extensive or more severe compression than patients who require just an ACDF. So there is some confounding involved as well. So outcomes of surgery are usually measured by a post-op. This is using a JOA score, not the MJOA score. So that is a point that to be remembered. So a recovery rate of less than 50% is considered to be a poor outcome. So what are the indications of, so this is a controversial topic. So when do you do anterior surgery? When do you do posterior surgery? When do you do a 360-degree surgery? But I think the indications for anterior discectomy and fusion are mainly to deal with 1 to 2 level disease. For anterior pathology, whether it be disc herniation and osteophytes, and when we are dealing with fixed cervical kyphosis of more than 10 degrees. Laminectomy and fusion is a reasonable option when you deal with multiple compression and a fixed cervical kyphosis of less than 10 degrees and presence of instability. Laminoplasty can be performed when you have multi-level compression, but fixed cervical kyphosis has to be less than 13 degrees. So the factors that would promote one approach over the other is sagittal malalignment and kyphosis, which is fixed in nature. You would prefer to do an anterior or posterior with fusion. When you're dealing with three or more levels of disease, a posterior approach is usually preferred. More elderly patients, greater morbidities, usually a posterior approach is preferred. When there is a high preoperative axial pain levels, usually a fusion procedure is preferred over just a motion preserving procedure. And when you have instability, again, you obviously have to do a fusion surgery. So this is a patient who underwent laminoplasty, and you can see this is a hinged laminoplasty where the troughs are made completely on the left side and partially on the right side. So what you do is you make a green stick fracture on the right side of the lamina and the facet junction, and then break the lamina and then fix the lamina with a with a mini plate to achieve expansion of the spinal cord area. So there are multiple types of laminoplasties. If I remember correctly, there are more than 15 variations of laminoplasties. The four basic variations are the Z laminoplasty, which was described first in literature. However, it being more cumbersome and more time consuming, it has fallen out of favor. The example which I showed was a type of a hinge door laminoplasty, where you make a green stick fracture on one side and a complete trough on the other side, and then use a non-absorbable suture which passes through this lamina and the facet joint, or place a bone graft here. Which bone graft was used here? We used a mini plate there instead. Again, for a hinge door laminoplasty, the important thing to remember is the place where you open the laminoplasty has to be the more symptomatic side. So the patient has to be more symptomatic on the side where the laminoplasty is opened. Where you make the green stick fracture is the side where the patient is asymptomatic or doesn't have too much of radicular symptoms. The other option was the midline enlargement, where the spinous process and the lamina was split in the center, and then a bone graft was placed in between to cause an expansion of the spinal canal. The other very common technique which is used is a bilateral mini plate technique, where you make the troughs on the both lamina facet junction, take the lamina out en bloc, and then fix it back with mini plates. So again, this is again a matter of some controversy, fusion versus no fusion, which we alluded to a bit earlier. But segmental instability with subluxation of more than 3.5 mm on static X-rays and more than 4 mm on dynamic X-rays is usually an indication for fusion. So, for example, this patient, you can see compression mainly at C34 and C56 levels, and you would think that targeting only these two areas with a laminoplasty may be sufficient. However, as soon as we did a flexion extension X-ray, we noted that there was a instability which was latent at the C4, C5 level. So the skip level, so as to speak, also had a degree of instability, and then this patient went ahead and had a fusion, the posterior laminectomy fusion, C3 to C6. Similarly, this another complex patient of multi-level cervical spondylotic myelopathy, and here patient has a Klippel field anomaly, not one but two, a C2-3 Klippel field anomaly and a C4-5 Klippel field anomaly, and a very hypermobile and instability in the spine, and this patient also required a spinal instrumentation. The second indication for fusion is presence of kyphosis, especially if it is flexible, or a sagittal vertical axis, which is more than 40 mm. So this patient, as you can see, was grossly kyphotic before surgery with multiple levels of cord compression. This patient, we could achieve a good correction from a posterior approach alone, since the patient was quite old, and 360-degree procedures are known to have much more complications in the region of about 50% of the patients who undergo a anterior posterior combined approach have complications. The another interesting thing is the MRI, post-op MRI that you see here, that you can see that there is regression of all the osteophytes. This is a 1-year follow-up MRI, and you can see that there is definite regression of the osteophytes. Again, this is another theoretical advantage of a fusion procedure compared to a motion preserving procedure. The other relative indications of fusion are when you do 4 or more levels of laminectomy or laminoplasty, when you're removing main muscle anchors like C2 or C7, usually fusion is recommended in those cases. So what are the advantages of fusion or fixation? First is you can correct the kyphosis, you can correct the sagittal malalignment. There is a lesser axial neck pain in the post-op period and the follow-up period. Whenever you deal with listhesis or segmental instability, fusion is preferred. It is Fixation is shown to have lowered the growth rate of OPLL by about 8 times. You will see a few patients, a few case reports where OPLL patients undergo a laminoplasty. However, the OPLL keeps on growing over a period of time, and over a period of long follow-up, patients do need a secondary procedure sometimes. Regression of the disc osteophyte complex, as I showed in the previous example, is again important advantage of fixation. And removing the motion across a disease segment is a key component of effectiveness of surgery. So if you remember the pathophysiology, which I showed you in the previous slides, everything starts with degeneration of the discs and hypermobility, the dynamic factors of compression. So motion preservation goes exactly against this thinking of our understanding of pathophysiology of degenerative cervical myelopathy. Complications rate from an anterior approach are different, and the complication rates of posterior approach are different. They have their own set of complications. You have to weigh in both of them together and then make a final treatment plan for a patient. Anterior approaches generally have a higher rate of pseudarthrosis, that is non-union. They have higher incidence of dysphagia, dysphonia, sometimes more blood loss, and a longer duration of surgery. Posterior approaches, on the other hand, have a longer hospital stay, more postoperative pain, slightly higher incidence of C5 palsy compared to anterior approaches, and wound infection. Now, the reason for the C5 palsy is especially in the posterior approaches, once the spinal cord is adequately decompressed posteriorly, the spinal cord floats backwards and it kind of stretches the exiting C5 nerve root, which is more perpendicular to the spinal cord. The other nerve roots are more angled and hence they can tolerate the stretch much better. However, the C5 being more vertical to the spinal cord, there's a higher incidence of C5 palsies in a posterior approach. Again, there is a lot of controversy regarding what is the exact pathophysiology of a C5 palsy. Now sometimes a delayed ischemic episode is also considered to be a causative factor for a C5 palsy. So currently, what are the surgeon preferences? So I took these two spine surveys which have been done in the past. The first one is the APSS spine survey, or the Asia Pacific spine survey. So the Asia Pacific spine surgeons would include countries like India, China, Japan, Korea, etc. And as you can see, for OPLL of more than 3 levels, the preferred procedure for Asian Spine Surgery Society is a laminoplasty, LP, being done in about 50% of patients. Whereas in cervical spondylotic myelopathy as well, of 3 or more levels, again the main procedure which is preferred is the laminoplasty. However, this is exactly opposite to what the North American spine surgeon survey showed, which showed laminectomy and fusion or instrumentation was the most preferred procedure for degenerative cervical myelopathy. And laminoplasty wasn't as popular as the other procedures. So there is definitely a geographical preference as well as which surgeons prefer a fusion procedure, which surgeons prefer a laminoplasty procedure. I think it all depends on your training background and the place where you get trained. So surgery for cervical radicular. So what are the current knowledge gaps? The current knowledge gaps are that we are still unsure as to what is the first choice for cervical radiculopathy? We have seen that the medium term data shows that this replacement is the probably the first choice. However, the long term data is still lacking. Hence, some surgeons still consider ACDF to be the first choice for radiculopathy. However, there's an emerging group of minimally invasive spine surgeons who would believe that doing posterior lamina foraminotomy is an equally good option, especially when the cost involved is much lesser compared to an ACDF or a disc replacement, since there are no implants which are used in a posterior lamina foraminotomy approach. Anterior versus posterior approaches, there is still emerging consensus, but there are still a lot of gray areas as to where you are going to do an anterior or where you're going to do a posterior or even a combined procedure. We do not have enough comparative data about other techniques of decompression like oblique corpectomies, skip laminectomies, MIS procedures, cassette fixation surgeries for cervical spondylotic myelopathy. Also remember that the degenerative cervical myelopathy is a very heterogeneous disease. The patient factors are heterogeneous. The surgeries have multiple variations. The outcome parameters are measured in significantly different ways, and hence generalizations become difficult. We do not have class 1 or class 2 evidence to say that one technique is better than the other. Our knowledge of cervical deformity parameters, which have picked up significantly in the last 3 or 4 years, are also evolving, and it would be interesting to see how it pans out over a period of time. Management of asymptomatic patients with severe radiological compression is again a matter of debate. However, there is some consensus which says that non-operative management should be the first choice, provided you have regular follow-up of these patients. And the final debate is whether instrumentation is better or motion preservation is better for cases of myelopathy. Now you will see a lot of case series where disc replacement is done for patients with myelopathy. In the past, this replacement was done only for patients with radiculopathy, but there is now an emerging trend where this replacement is also being done for patients with myelopathy. So what are the future in degenerative cervical myelopathy? So main thing is going to be improvement in imaging. As I told you before, we still do not have good cutoff values for apparent diffusion coefficient and the fractional anisotropy for our DTI imaging in the spine. And once we get that, it will be much more easier and much better to prognosticate our patients. Serum biomarkers is another interesting field where you measure the serum microRNAs. So serum microRNA 21 for neuroinflammation, microRNA 34A for apoptosis, and microRNA 10A for ossified posterior longitudinal ligament are some of the biomarkers which are recently being studied. The other interesting thing is an AI-based prediction model for outcomes. So you put in the data like age, sex, BMI, pre-op MJOA score, the radiological findings like the Cobb angle, the SVA, the K-line parameters into an AI model, and the AI model shows which surgery would give you how much post-op MJOA score. So that is something which is being developed right now. It is still in an early phase, but that is certainly something which would take the guessing out of the decision making for cervical myelopathies. Again, another new technique is the gene therapy to upregulate anamolism, that is to basically repair the injured disc. These are basically looking at the metalloproteases and the transmembrane proteases. And finally, the MISS techniques of focal diseases or hybrid mini-open techniques for surgery or short instrumentation, fixation, and decompression. How do they stand compared to a regular open anterior or posterior approach? That is really something which we need to look forward to. Thank you.
Thanks, Chandan. That was quite a comprehensive coverage of the problem of degenerative cervical myelopathy. There is one question in the box, but before that, I would like to ask you, you have shown some pathologies, but I wasn't very clear in the analysis. The difference in practice between the American and the Asian population, or the population of surgeons, is it because we see more OPLL in Asia, or is it independent of that?
So it was so at least in the survey it was independent of that. So as I told that there is a leading group of surgeons, especially senior surgeons, who believe that instrumentation causes regression or slows the growth of OPLL. Now this is a theoretical advantage, but that is something which is being very aggressively promoted as one of the reasons for fixation over doing a motion preserving surgery.
Question which has come in the question box is regarding routine use of spectroscopy and the advantages which or the markers which you have shown for MR markers for prognosis, like ADC and FA. So do you recommend it to be done regularly, or are there centers which are doing it regularly?
There are definitely centers which are doing it regularly now. Unfortunately, a lot of it is operator dependent still. So your radiologist needs to have good expertise in interpreting the images as well. As I told you, we do not have clear cutoff. ADC more than X level or FA more than X level is going to be important or not, and you need EC and FA levels at each level, that's T2, T4, T4, 5, T5, 6, age, sex parameters. So we don't have that cutoff level. However, the long track, it's the blue column which I showed. If they are impaired on the DTI images, then usually means the prognosis is poor for these patients, irrespective of whether they have severe changes on the T288 or T1
There is
images.
unfortunately a lot of noise coming. So, but we get the point. There is another question which I am unable to read fully about corpectomy. Ajay, can you read out the question?
Yes, sir. So, sir, there's a question. Can we do corpectomy with expandable cage placement in patient with CSM and TFO? Which should be addressed first?
I did not get the question.
Whoever is, wherever there is noise coming from, please mute yourself.
Can I ask a question?
Yes, sir. Okay. The question is, can we do corpectomy with expandable cage placement in patients with CSM and TFO? Which one should be addressed first?
With CSM and cathode cord?
Yeah.
So I'm not sure if I get the question correctly, but whether can we use expandable cages? Yes, expandable cages can be used for corpectomies in patients with cervical myelopathies. The only thing is that some of the recent data is what it shows is that if you have an option of doing a corpectomy versus multi-level ACDF, you prefer to do a multi-level ACDF rather than doing a corpectomy, because it shows that the rate of pseudoarthrosis with a corpectomy procedure is as high as 20%. Whereas for ACDF procedure, it is slightly less, it's single digits. So that is the only difference.
Can I ask a question?
Dr. and Dr. Turel have some questions.
Yes,
Please go ahead.
Chandan, very good presentation about this problem. My question is that, we have been talking a lot about the adjacent segment disease or degeneration after instrumentation or surgery. What is your comment? What is the latest comment about this or theory about this problem, adjacent segment degeneration?
So there are two parts to it. So one is adjacent segment disease, which is radiological, and the second is adjacent segment disease, which is clinical. So radiological adjacent segment degeneration is seen in about 25% of patients at the end of 10 years. So in 10 years, you will see 25% of patients who have radiological disease. However, clinical adjacent segment disease in 10 years is in single digits, is again close to 8 or 9%, is not very high. So again, now there are proponents of anterior cervical arthroplasty who believe that you can actually prevent adjacent segment disease by doing a arthroplasty as a first step. So that is one of their arguments. However, as I told you, the main problem with arthroplasty is that 6-year, 8-year, 9-year data is showing that there is calcification which is setting in near the implants. But at the end of the day, that is also getting calcified and it is akin to a ACA procedure. So we are waiting for long-term data to come from the cervical artificial disc replacement arm to really comment on how we're going to deal with it. As of now, it is something which for all the juniors, I would say that for every patient whom you plan for surgery for myelopathy, you should counsel them that there is about a 5 to 10% risk of you requiring another surgery at the adjacent level in the next 10 years. I think that will be a simpler way to for the juniors and the residents.
Right. Thank you.
So Surel has the last question.
So I had a question. I don't know, Dr. Dev Pujari. Hello. May I ask a question?
Please go ahead yourself. Yeah.
So my question was, if you have cervical myelopathy in a patient with canal stenosis, what is the approach that you would choose, anterior or posterior?
Sir has asked the most controversial question. There has been a lot of debate. But if there is canal stenosis with spondylotic changes, first thing I personally would look for three things. First is the age. More the age, the more it would make me prefer posterior approach. If the disease is 3 levels or more than 3 levels, I would prefer a posterior approach. And if there is adequate lordosis, I would go for posterior level. So lordosis, more than 3 level disease, advanced stage, posterior. Less than 3 levels, kyphosis, young patient, I would do an anterior approach.
Thanks,
Okay.
Chandan. I think Vernon,
Yeah. Thank you, Dr.
can
Dev
move
Pujari.
on to the
Thank you,
next
Dr. Chandan. Just an announcement. Since Dr. Sukhdeep Jawar could not complete his presentation because of a power cut, we shall have his presentation. He's got some beautiful slides to show. We would have it at the end of the program after all the speakers. And I would like the participants who really want to learn to be tuned in. You all can have your lunch while watching the webinar also. So basically, this is a learning platform. So I would request the speakers to stick to a time of 25 minutes, and we'll give you another 2-3 minutes extra so that it does not shoot overboard. So I would like to invite Professor Deepak Gupta to introduce the next speaker, please.
So from pituitary, cervical spine, and now next we move on to the aneurysms. So we have with us Dr. Harshikesh he's an associate professor of neurosurgery at Grand Medical College and JJ Group of Hospitals. He's a very ardent and excellent speaker, and he's the upcoming cerebrovascular surgeon of our country. Without wasting any time, I would hand it over to Dr. Harshikesh.
Hello. Thank you, sir, for the introduction. Firstly, good afternoon, eminent teachers. I would like to thank Vello, sir, and Baxter to giving me the opportunity to speak in such an eminent forum. So today I am going to speak on management of middle cerebral artery aneurysms. Why middle cerebral artery aneurysms? Because these are kind of job security for vascular surgeons like us, because most of these aneurysms are peripherally located and preferentially microsurgically clipped. So this is the institute where I work as associate professor. So 20 to 20 middle cerebral artery aneurysm make to 25% of the all intracranial aneurysms. 80% of them are seen at the bifurcation. Majority of the middle cerebral artery aneurysms are treated with microsurgical clipping. Microsurgical clipping of these aneurysms is easier than in other locations because of their peripheral locations. Even though giant size, wide neck with major arterial branches arising at the base and the frequent need to reconstruct the vessel and preserve the MCA bifurcation makes them challenging to treat.
So what are the unique features of MC aneurysms? They may grow up to the size of 2 to 2.5 centimeters or larger than that before the detection. They are more likely to present with intraparenchymal hematoma, more likely to cause the symptoms of mass effect than other intracranial aneurysms. They are more challenging to treat with endovascular techniques than other aneurysms. So most important part of treating or surgically clipping MC aneurysms is to know the complex anatomy of middle cerebral artery. Middle cerebral artery is the largest and most complex of the cerebral arteries. It arises as the larger of the two terminal branches of internal carotid artery. The diameter of MCA at its origins ranges from 2.4 to 4.6 millimeters and is roughly twice that of anterior cerebral artery. Middle cerebral artery is divided into four segments anatomically, M1, M2, and M3. M4, M1 is sphenoidal segment, which is also called as the horizontal segment. M2 is the insular segment, which begins at the genu and lies over the surface of the insula. M3 is opercular segment, and M4 is the cortical segment, which supplies the cortical surface of the brain. So this is lateral and superior view, which can be seen intraoperatively also, showing different segments, that is M1, M2, M3 segments, and these are the important branches, lenticular striate arteries. This is the axial view of base of the skull. This is the anterior part and this is the posterior part. And you can see the origin of anterior cerebral artery, and this is middle cerebral artery. This is the M1 segment, which takes a 90-degree curve, which is very important surgically, into M2, then the bifurcation. These are the M3 segment, and on this view, you can see the M4 segment or the cortical segment. Now, this 90-degree curves, usually anatomically, MCA makes these kind of 90-degree curves in different superior, inferior, and vertical planes, which makes it more prone for aneurysm formation, and this is the most common site of aneurysm formation. Important part is the origin of lenticular striate arteries just beside this. So during aneurysm surgery, we have to preserve these lenticular striate arteries. Another important part which we have to know while doing surgical clipping of these aneurysms is branching pattern of M1. There are 11 different branching patterns of middle cerebral artery. Those are monopurgations, tetrapurgations, then pseudo-tetrapurgation, medial bifurcation, lateral bifurcation, trifurcations, and pseudo-trifurcation, which you have to see pre-operatively while you are going to plan the clipping of neck of these aneurysms. Then middle cerebral artery branches in two. It is perforating branches and the cortical branches. Perforating branches, which are called as lenticular striate arteries, which branch and usually from the M1 segment of middle cerebral artery and enter the anterior perforating substance. They are divided by some authors in three groups, that is medial, intermediate, and lateral group, and by some author in medial and lateral group. The medial is the least constant of it, which has 1 to 5 branches and enters the medial anterior perforating substance. The intermediate one is the constant one, and the lateral, which is S-shaped in course and enters the posterolateral part of the anterior perforating substance. These traverse the APS and then supply to caudate nucleus, putamen, globus pallidus, and some part of internal capsule. So it is very important during surgery to preserve these perforating branches. So this is the diagrammatic representation of right-sided middle cerebral artery after the superficial frontal cortex is been removed, and you can see these are the perforating branches which origin some part from M1 segment and some from ACA. And after retracting the temporal lobe downwards, you can see the M2 segment which is lying on the superficially on the insula. These are the M4 segment or the cortical branches of middle cerebral artery, and this is the cortical area which is supplied by middle cerebral artery. Important part is anomalies of middle cerebral artery. These are rare compared to other intracranial arteries, but majority of include duplication or accessory middle cerebral artery, fenestration, early bifurcation, superior dominant, inferior dominant, or trifurcation. Duplication is when there is an accessory M1 segment which is arising from the internal carotid artery, and accessory is when the M1 segment is arising from the anterior cerebral artery. So it is very important to know. Coming down to classification of these MC aneurysms, they can be classified based on their morphology into saccular aneurysm, fusiform aneurysm, blister aneurysm, or infectious aneurysms, which are usually at the M4 branches. According to their size, as small, medium, large, and giant aneurysms. Yasargil has classified them in relation to the nearest branch into anterior, temporal, lenticular striate, bifurcation, second bifurcation, or distal aneurysms. According to location, they can be classified into three types. That is, first is MCA bifurcation or trifurcation aneurysms, which constitutes 90% of these aneurysms are surgically clippable. Then proximal MC aneurysms and distal MC aneurysms. The proximal MC aneurysms are further divided into superior wall type, which arise from the origins of the lenticular striate arteries and usually project into the frontal lobe, and inferior wall type aneurysms, which origin near the anterior temporal artery or temporopolar artery and project into the temporal lobe. Distal MC aneurysms, which are usually uncommon, either infectious or traumatic, they can be challenging for surgery because of their small size. Etiologically, these aneurysms are classified into baryaneurysms, saccular aneurysms at the sites of arterial curves or branchings because of the hemodynamic forces. Then infectious or mycotic aneurysms, which are found along the distal branches of the MCA, secondary to infectious emboli or bacterial endocarditis, or neoplastic diseases such as choriocarcinoma, atrial myxoma. The fusiform aneurysms, and then the dissecting aneurysms, which may be associated with infection or connective tissue disorders like Marfan syndrome or fibromuscular dysplasia. Usually, these are rare aneurysms and present with ischemia or subarachnoid hemorrhage. Traumatic aneurysms are seen usually at the M3 or M4 segments are usually uncommon. So now a newer classification proposed by Professor Jaakko Kato, which is based on the intraoperative findings and the 3D CT angiography findings preoperatively. They are divided these into 5 types, which is very important for surgical clipping of these aneurysms. So they are the type 1, which are called as simple aneurysms, are bulging from a well-circumscribed weakness in the wall at the site of maximum hemodynamic state, which is seen at the bifurcation, and which is not, this wall of aneurysm is not extending on the M1 segment in the proximal direction. Type 2 aneurysms are also called as central type. In these, the aneurysmal wall or portion of it is extending on the M1 segment proximally and saddling over the bifurcation. Type 3 are called as complicated neck aneurysms, where there is a perforator or branch of it is emerging from the neck of the aneurysm. Type 4 or complex aneurysm, these are the aneurysm in which the M2 branches are seen to be arising from the aneurysm rather than from M1 because of the involvement of wall of M1 or M2. And type 5 are also called as blister aneurysm. So this new classification is very important for microsurgical clipping of MC aneurysms. The presentation, 50% of these aneurysms usually present with subarachnoid hemorrhage, 15 to 20% can present with large intracranial hematoma. Then because of their propensity to become quite large before detection, they can be symptomatic even without subarachnoid hemorrhage, like in giant aneurysm can present with seizures or hemianopia, hemiparesis, and if it is in the dominant lobe, they can present with speech disturbances. Evaluation of these patients usually done routine CT scan of the brain, which will show subarachnoid hemorrhage or intracranial hematoma. Then 3D CT angiography, which is 3D recon of the CT angiography, is very important in these aneurysms to see the plane in which the aneurysm is projecting and plane in which the neck is there, and what are the branches which are emerging from the neck or from the dome, and planning the surgical clipping of this. And digital subtraction angiography is the gold standard investigation in these aneurysms. So coming to management of these aneurysms, different strategies for management of MC aneurysm include simple microsurgical clipping. Most of them might need clip reconstruction, endovascular treatment, ST-MCA bypass, and observation in specific indication when there are small blister aneurysms in a dominant lobe and unruptured aneurysms. So MC aneurysms are preferentially clipped at most centers because of their broad-based configuration, relatively small caliber of the surrounding branches, which often precludes the use of stents, and their classic bifurcation location makes the recurrence more likely. So the first successful direct clipping of the MC aneurysm was done almost 7 decades ago in Edinburgh by Sir Norman Dodd, who opened the large MC aneurysm and packed it with the fundus with piece of muscle. Later on, Walter Dandy published his personal series of clip ligation of intracranial aneurysms, which included 4 MC aneurysms, which effectively launched the new era of aneurysm treatment. Yasser and his anatomic microsurgical descriptions of intracranial vessels, cisterns has transformed the MC aneurysm surgery from a highly morbid procedure to a sophisticated art of a careful arachnoid dissection and effective use of natural anatomic corridors. Endovascular therapy, which started in early 90s, is currently expanding its role in management of these MC aneurysms. So the complexity of an MC aneurysm clipping lies in the size of these aneurysms, which are usually large to giant at the presentation, relationships to the different MCA branches, location of lenticular striate arteries in relationship to these aneurysms, as we have to preserve these arteries, projection of the aneurysm in the plane of compared to plane of the parent vessel, presence of calcification in the aneurysm neck and dome, and partial or complete thrombosis of these aneurysms. The craniotomy for these aneurysm clipping is usual pterional craniotomy. Important point is to preserve the superficial temporal artery early in the craniotomy position. The head is turned about 30 degrees to opposite side with vertex slightly extended. An important part of this surgery is to how to dissect the middle cerebral artery and dissection of the Sylvian fissure. So dissection of Sylvian fissure carries very much importance in all of the aneurysm surgery. The Sylvian fissure can be atrophic, which makes life easy for any vascular surgeon. It can be opposed fissure, it can be frontal herniating or temporal herniating fissure. So important point while exposing the MC is you have to see the anatomy of Sylvian veins and start the cortical arachnoid dissection distal to these Sylvian veins, mostly on the frontal side, and push these Sylvian veins to the temporal side. Important point is to preserve the traversing veins which are draining into the Sylvian veins on the temporal side, as these are draining into the spinoparietal sinus. Some of the veins draining on the frontal side into the Sylvian veins can be sacrificed. Usually you have to avoid sacrificing the veins, but you can sacrifice on the frontal side, but not on the temporal side. So after dissecting the Sylvian fissure up to this sphenoidal cistern, then you trace the cortical branches of the MCA down to the opercular branches and then to the superior and inferior trunk and leading you to the aneurysm. So this is the way Sylvian fissure is opened. Then dissecting the MCA aneurysm, there are 2 different strategies. One is distal to proximal MCA aneurysm dissection. This is slightly tricky or risky in cases of ruptured aneurysm, as there is no proximal control in this. This is preferred in an unruptured aneurysm where you follow the superior trunk of the MCA leading you to the M1 segment and then take the proximal control and then follow the superior trunk into inner from inner surface, inferior trunk leading you to the neck of the aneurysm. So this is usually preferred in unruptured aneurysm. What we do in our institute is proximal to distal aneurysm dissection, because most of the aneurysm which present to us are in ruptured aneurysm. So in this, you directly go to the supraclinoid ICA after and dissect the A1 segment and the M1 segment and take early proximal control of the M1, and then come distally dissecting the MCA with outer and inner surface of the superior trunk, then the inferior trunk leading you to the neck of the aneurysm, and then clip the aneurysm. So there are different clipping techniques which you have to know when you're doing microsurgical clipping of this MC aneurysm. Not all the aneurysm can be clipped with simple technique. You have to know multiple clip techniques. Then you have to do the tandem clipping of these of the aneurysm sac. The multiple clips are applied perpendicular to the sac while preserving the lumen of the parent vessel. Then there is use of fenestrated clips where you have to preserve the branch of the or the perforator which is originating from the neck or dome of the aneurysm, and then multiple clip reconstruction of the vessel wall. So in case of unruptured aneurysm or small laterally pointing ruptured aneurysm at the bifurcation, first you go distally, take the control of M1, proximal control without opening the fissure first. In large ruptured aneurysm with uncertain anatomy, the fissure dissection should be wide, include the proximal control initially at the opticocarotid sisters and then work distally until the proximal M1 is identified. In multi-lobed aneurysm, you have to be ready with more than one clip, and you have to know the imaginative clip constructions. Large multi-lobulated aneurysm with calcified or atheromatous wall, the closure of the clips can be tricky. So in these aneurysms, you have to know the tandem clipping technique, or fenestrated clip has to be handy. So what are the important points to remember is for sharp dissection, clear the aneurysm neck, be aware of the small branches which might be adherent to the dome, which I'll show in the video. Then temporary clip has to be ready for the proximal control, and clips should be applied parallel to the branch of vessel to avoid possible remnants and to re-establish the normal anatomic flow. So now this is a giant aneurysm on the right side, which we have clipped with multiple clip techniques and tandem clipping. So first we are going to the proximal control. The supraclinoid ICA has to be exposed. So this you can see is the ICA. Then you come behind to identify the M1 and M1 segment. Now you can see gradually in this patient there was a large intraparenchymal hematoma which guides us to the aneurysmal sac. So now we are taking the proximal control at the M1 segment which has been identified, and then clearly defining the neck is very important. So now the neck is defined. You can see a perforated branch originating from the dome of the aneurysm. So this is the first clip which has been applied at the neck. You can see the vessel which is preserved here. Then multiple branches which are adherent, not arising but adherent at the dome are separated. The temporary clip has been removed. And this is the reinforcement clip which has been applied over the first clip. And now multiple tandem clips we apply over this, that still there is filling of the sac. So this is called clip reconstruction using multiple tandem clips. And then intraoperative ICG has been done. There's no filling of the aneurysm sac, and a well-established distal flow can be seen. So this is another case of large, not a giant, but large MC aneurysm, where again the clip reconstruction has been done. The opening of the sylvian is same, where we go from proximal to distal, take early proximal control. So you can see there's a lot of intraparenchymal clot and multiple branches which are adherent to the sac. Now the clip is applied at the neck. So the vessels with the adherent are separated and dome is separated from the adhesions. So clip is now readjusted. The reinforcement clip has been applied. Now what we do is clip reconstruction of the parent vessels. As you can see, small remnants of the sac can be seen, but you have to preserve this parent vessel. So multiple clip technique is used to reconstruct the lumen of the parent vessel. Then the sac was opened. It was partially thrombosed aneurysm. This is intraoperative ultrasound showing no filling of the aneurysm sac and very good distal flow. So now this is an interesting case where the patient presented to us with ruptured ACOM aneurysm, but on DSA we could see is another distal flow related MC aneurysm. So as it was distal flow related on the same trajectory, we went ahead, first clipped the ACOM aneurysm, and in the same setting, we came back and clipped the MC aneurysm also. So first this is dissecting the ACOM aneurysm. So clipping the ACOM aneurysm. So the reinforcement clip has been applied for the residual part of the sac. Opening the lamina. And now coming back, and the distal flow related MC aneurysm can be seen at the bifurcation. So it was also clipped with preservation of the proximal distal vessel. Intraoperative ICG. So now this is a case of large MCA bifurcation aneurysm in a medical student who presented to us with a headache and very minimal subarachnoid hemorrhage. So the steps are similar. Now you can see as this is the aneurysm which can be seen, dome of the aneurysm can be seen early. So you have to very carefully dissect as patient has only minimal subarachnoid which can be seen xanthochromia. Dome or the sac of the aneurysm is adherent to the parenchyma which has to be gradually separated. So now taking first clip, this is applied. But as the aneurysm was still filling, then we applied the temporary clip for proximal control. And that makes life easy to dissect the dome. So now readjusting the permanent clips at the neck. Removing the temporary clip. A reinforcement clip. And excising the sac of this partially thrombosed aneurysm. This is a case of MCA bifurcation aneurysm with calcified wall. As I said, the calcification of neck makes clipping slightly tricky as the aneurysm can rupture while applying the clip. So now dissecting the aneurysm at the bifurcation, you can see it is completely calcified. So curved clip has been applied parallel to the direction of the parent vessel. And small mini clip It's reinforcement of the residual side. So intraoperative ICG. So in good filling of the distal part of the vessel. So coming to endovascular management of MC aneurysms. MC aneurysm are considered more favorable clipping because of the superficial location, bifurcated anatomy, broad neck, a prevalent perception that endovascular treatment entails high risk and lower durability compared to open surgery. But recent years, however, the MC aneurysm surgery has been challenged by use of new endovascular devices like dedicated intracranial stents, sophisticated coils, flow diverters, and intrasaccular devices. So Heller has provided a practical classification for endovascular treatment of MCA bifurcation aneurysm based on two anatomic features, that is angulation of M2 trunks relative to the parent artery and aneurysm dome neck ratio. So what he has done, similar to what Professor Kato has published, he has classified these into 5 types. Type 1 lesions with favorable dome neck ratio where simple primary coiling can be done. Type 2 is wide neck aneurysm with single MCA trunk branching at the oblique angle. A stent reconstructed with single stent across the aneurysm neck followed by coiling can be done. Type 3 are these aneurysms with one MCA trunk branching at the acute 90-degree angle. In these, you need is a balloon assisted techniques to protect the daughter vessel and allow embolization of the aneurysm. Type 4 are wide neck aneurysm with both the MCA trunks are branching at the oblique angles. In these, the neck is reconstructed with Y-stent techniques to protect the daughter vessels followed by coil embolization. And type 5 are wide neck lesions with both the MCA trunks are branching at acute angles. In these, you need is a waffle cone stenting technique in which the stent is deployed inside the aneurysm sac, providing a scaffold for coil embolization. So this is the Heller's classification, which was present 2017. Bypass is reserved for fusiform giant aneurysm, where STM-say bypass end to side or side to side has been done. So to conclude, aneurysms of MCA continue to pose challenges to the neurosurgeon because of the complexity of anatomy of middle cerebral artery. Many of these aneurysms present with mass lesions due to intracranial hematoma. So direct evacuation of hematoma with concurrent clipping is the preferred method of treatment. Microsurgical clipping still remains the gold standard in this era of evolving endovascular management of different aneurysms. Thank you.
Thank you. Deepak, are you there?
Yeah, Yeah, I think excellent presentation. I don't see any question from the attendees here, but I think he has covered it very nicely and talked about all the surgical basic principles. And yes, there is a role of endovascular treatment, but yes, at the same time, we need to look at the cost issues also, economics. Like when the economics are there, then I think surgery always outscores, as compared to the endovascular, which are much more expensive. And you need to have a steep learning curve also for endovascular treatment for MCN. I don't think there are any other questions. In the interest of time, I think we should move on to the next speaker.
Yeah, thank you, Deepak. Thank you, Rushikesh. And we shall move to Professor Turel now and to introduce our next speaker, who is his son, Dr. Mazda Turel. Professor Turel, over to you.
Thank you. Can you hear? Yeah?
Yes, yes.
Okay, excellent. So, well, Vernon, thank you very much for this rare delight. It's a great symposium. You've taken a great initiative in educating young people, and I think this initiative should continue. I congratulate you for this idea.
Thank you, thank you.
Mazda is not only my son, but I think one of the brightest young surgeons in our country. And he's a proud product of JJ, passing out from MBBS in 2005, and then he went on to the Center of Excellence, CMC Vellore, where he passed off with flying colors in 2012 with the coveted uncommon Jacob Chandy medal, gold medal. After that, he went on to Canada for skull-base surgery at Fred Gentili, and then to Rush University in Chicago for complex spine. Mazda is a prolific writer, as I know him, and he's done by now 80 papers in peer-reviewed journals, 10 textbook chapters, 60 presentations, and at least 100 newspaper articles, which are now become quite a common thing for people to read. Well, he also did some bypass surgery experience with Pinshu in Shanghai, the man who has done the maximum bypasses in the world, over 6,000, I believe. So now Mazda is back in Mumbai, and he's here in Wockhardt, and also back to his alma mater, JJ Hospital, under the stable leadership of our chief moderator of the day, Vernon Velho. So back to Mazda, he's going to talk on a very important subject, value of neurology and radiology in neurosurgery, which is really something that is very close to our ideology of complication avoidance. And this, I'm very eager to learn. I'm very eager to listen to Mazda. Let's see what you can say. Thank you very much for this.
Hello and good afternoon, everybody, my seniors, colleagues, and everybody viewing. This is a lecture I have prepared specifically for residents and junior neurosurgeons like myself, who have to go through this learning experience, practical learning experience on their own. And I'm going to straight away delve into case presentations. And I hope everybody can hear me and see me, so I'm not going to ask these questions anymore. So this is a 55-year-old lady presented with low back pain for 2 years and a gradual onset right-sided foot drop. She had some episodes of right-sided numbness and tingling in the legs. And the natural tendency was to do an MRI of the lumbar spine. She had a foot drop. Nobody hesitated to go and do a lumbar discectomy for this lady. And she did not improve after surgery. The post-op MRI looks pretty good. There doesn't seem to be any residual compression. But when she came to us, we examined her in detail, and the power at the ankle was 0, but she had a spastic right lower limb with exaggerated knee jerks. And we carefully examined the parieto-cortical sensations in the right foot, and those were absent compared to the left side. So automatically, this completely changes the localization, and we asked for an MRI brain that showed a large middle third parasagittal meningioma, which we excised, and there was a significant recovery of the foot drop at 6 months. So the value of this particular case is that a spastic foot can never be due to a lumbar spine problem. You have to evaluate higher up, and you have to understand the anatomy of the foot drop in great detail. This is a 65-year-old lady who came with low back pain and severe left-sided neurogenic claudication. She could not walk for more than 5 minutes, and she had had an L4-5 laminectomy and a discectomy elsewhere with no relief of pain. And she came from abroad and said that you have to operate on me. There is no other option because I cannot live with this pain, and my surgeons have told me that I will need another operation. And she was convinced. She was convinced that her symptoms were due to the lumbar spine problem and nothing else. And her description of the L5 radiculopathy was so classical. She had severe back pain and she had typical L5 radicular pain, which one would never even think of anything else. But the MRI just looked so capacious. The canal was wide. There was no stenosis. There were some footprints of the previous surgery done elsewhere, but I was not at all convinced that this is something that requires an operation. And we examined her in detail, and we felt her lower limb pulses, and she had an absent dorsalis pedis and a posterior tibial. She was a chronic smoker for the last 30 years, and while we know these descriptions of vascular and neurogenic claudication, and it's important to have them in the armamentarium, it is sometimes there can be a significant overlap. Vascular claudication can mimic neurogenic claudication and vice versa. And we got a Doppler and then we got a CT angio, and you can see that there's a 5 centimeter block at the aortofemoral junction, and that was actually even producing significant back pain, not only leg pain. And one could have easily been tempted to go ahead and operate on the spine, but we stented her, started on antiplatelets, 3-year follow-up. She still says that she's completely pain-free and she is indebted for this particular diagnosis. While we always read this in textbooks, very seldom do we actually tend to practice this. So in every case of suspected lumbar radiculopathy or claudication, please palpate the foot. This is a case that I will always take back from a 30-year-old lady with low back pain and severe right lower limb pain. She was seen in the middle of the night in the ER, in the emergency of a busy hospital. No particular dermatomal distribution. The resident saw her and said she's not moving her right leg, and spoke to the attending on the phone and sent him the MRI, and the diagnosis of impending cauda equina syndrome was made. The decision was made to operate in the night because we didn't want to cancel the next day's elective busy long list. And if you can see there is a significant disc there. It's pretty sizable. It's more on the right side. It matches with the... So an operation was done, a wide laminectomy was done because of cauda equina supposed. And when we turned her around after surgery, the right foot was pale, cold and pulseless. She actually had acute limb ischemia, required an emergency embolectomy, and then unfortunately a 4-foot amputation. Now, whether this was due to positioning, and I have seen that one case as well, or whether this was just acute limb ischemia to begin with, one will never know. But what I have learned in my training is that you always palpate the artery before positioning the patient and after positioning the patient prone. In the US, when we trained, we had every patient being monitored, and we were doing an exposure for a scoliosis operation. And just during the exposure, we had to drop in amplitude, and we had to close and turn the patient, and the amplitudes came back. So it either could be due to positioning, or it could be due to an acute limb ischemia from the beginning. We need to make sure that we are not missing the basics that we see. 65-year-old gentleman who presented with backache for 2 years with bilateral radicular pain but no claudication. And when I specifically asked him, he said his pain was worse only on lying down, no pain on walking. This was his X-ray. He could walk for 2-3 kilometers without any problem. The moment he lay down, he started having pain. It's very unusual for listhesis to present this way. You look at the MRI, it's straightforward, but you look carefully higher up. He has an intradural tumor at T12L1. And an intradural tumor can cause a lumbar radiculopathy at a lower level. One has to be extremely mindful of that. And we operated on him, we removed this intradural tumor, and he was completely pain-free. So intradural tumors almost always have pain on lying down, and they can mimic radiculopathy. Listhesis will always get worse on walking. Because this patient was in close follow-up, he came back 3 years later saying now his pain has started while walking. And he has significant pain while walking, and initially he could walk 3 kilometers. Now he can only walk for about 5 minutes and no pain on lying down. We did a dynamic X-rays. There was a little bit of an instability. We did an MIS T-lift and he's fine. Another gentleman who presented with just one episode of GTCS, a simple, straightforward calcified meningioma. You can decide whether you want to offer him surgery or you want to just keep him on anticonvulsants. We had that discussion. They were willing for surgery. We did an MRI of the brain, and look what we find in the MRI. If you can carefully look at the cervicomedullary junction, there is another large lesion there. And it's a big calcified chunk. There is absolutely no space for the spinal cord. So while the surgery for the meningioma is not at all a technical challenge and we removed it, what is important here is what are you going to do and how are you going to position the patient. Ideally, you would do this case just supine with the head slightly turned and you would be able to remove it. But would you turn someone's head with this kind of a lesion in the cervical spine? So you can do this with the head dead neutral in either the prone or the lateral position, and we use monitoring. Normally for this case, we would not use monitoring, but we use monitoring for the spinal cord to make sure that we are not making any damages, because he was absolutely asymptomatic for any spinal cord compression, not even exaggerated reflexes. We removed the brain tumor and it turned out to be a grade 2 meningioma. So even calcified meningiomas, when we discussed to leave alone, this is an interesting finding that it turned out to be a grade 2 meningioma. We did not give him RT, we did not, but he's followed up for the last 3 years with me, and he's been asymptomatic for the cervical lesion completely with no subtle signs of myelopathy as well. So while we don't chase incidental findings, it's important not to ignore them completely because they may be useful in our management of the problem that we are dealing with. This is a 26-year-old lady. Sudden onset progressive headache for the last 4 days only. Right-sided hemicranial throbbing, severe headache, worse on bending forward. No neurological deficit on detailed examination. The fundus was clear. It showed what initially looked like a chronic subdural hematoma or like an arachnoid cyst, but very large, causing some kind of mass effect on the brain. The neurologist called me saying, hey, you'll have to put in a burhole. This lady's got severe headache. I said, let's take a detailed look at the scan. And you see that this is just probably a congenital large cyst that's lying there. And it's remolded the bone as well. And I said that this does not look like something that is acute. And we need to rule out something more acute. Very recent history, side lock, postural variation, all these were red flags. I mean, you have to decide between what the heart feels and what the brain knows. I mean, it might be just easier to go make a small hole and relieve the pressure of that cyst, unless it had bled, and it had not bled inside. So we did an MRV, and I'm not sure if this is very clear, but you can see that the sigmoid sinus is completely thrombosed on the right side. And when we reviewed her history, she was taking oral contraceptive medication. She had a very recent history of travel in a hot, humid climate, and she actually had CVT. And we started her anticoagulation, and her headache completely resolved by the 3rd day, and with no recurrence, and we've not touched that cyst. So these are important clinical radiological correlations that need to be made, because CVT is an often missed cause of acute headache. It may not always present with a neurological deficit. This is a very interesting lady, 70-year-old lady, comes to us with acute hemiplegia. Right side, grade 0 power, right upper limb, lower limb, high blood pressure. Looking at this, we instantly thought and expected her MRI brain to show either an infarct in the left MCA territory or a hemorrhage in the capsuloganglionic lesion. Very less likely for it to be a Tod's paresis because she didn't have any witness of a seizure. We do an MR angio and an MR brain stroke protocol. That looks relatively good. I mean, except for age-related degenerated changes that happen in a 70-year-old, the angio didn't show. Sometimes you can have an acute stroke because of narrowing of the carotid and a stroke in evolution, and patient can be hemiplegic, but the DWI will not pick it up instantaneously, and that is the only indication for an emergency carotid endarterectomy. So what do you do? In a lady like this, can this be a stroke? Should you go ahead and thrombolize her to improve the neurological deficit and see? Can these findings be explained by a brain lesion? We again took a look at her in great detail because these are very time-sensitive decisions. If you have to thrombolize, you have to thrombolize it in the next 4 hours. I mean, within the 4-hour time period, and she already came 3 hours later. So the decision has to be made in 1 hour. It cannot be delayed. But she said she had a little bit of neck pain. When we examined her really carefully, there was noted to have a sensory disturbance in the right upper and lower limb and no facial paresis despite such a dense motor deficit. So we have to put our brains in the washing machine and think a little bit as to what this could be. What is the exact localization of this lesion? And you can see that she has a large spontaneous spinal cord hematoma from C2 to C5. We decided, okay, let's go put her back into the MRI. Let's image the spine. Are we missing something? And if you can see, can you see this? This right here on the right side is a large hematoma that is missed actually on even the mid-sagittal section of the spine. So you have to be very careful in evaluating something like this. And we said that surgery was the only reasonable option for her. And we did a cervical laminoplasty, and she recovered her neurological deficit at 3 days. And a DSA did not find a cause. There wasn't any vascular malformation, nor did an extensive hematological workup show any vascular pathology to suggest any thrombophilia like of situation. So be sensitive to the fact that acute spinal lesions can also cause a dense hemiplegia, and in absence of a facial paresis may be a guide.
Get up from the chair, lean forward, put weight on the legs and stand up straight. Yes. Now, walk. Yes.
So this
Take
is
a little bigger steps and yeah.
This is a gentleman who presented with difficulty in walking. I'm audible, right? I've reduced the volume of my video on the computer. And he presented with difficulty in walking. You can see some controlling kind of movements in his
walk
hands,
back.
but yet frequent falls, and he was diagnosed to have Parkinson's. And an MRI brain was done, which was normal. And he was started on Syndopa medication. And for 6 months, he was continuing to worsen. And he came to us for an opinion. And I saw him and noticed that both his limbs were severely spastic, lower limbs. And he almost had an ankle flowness with severe band-like sensation in the waist, very painful sensations in the crotch with exaggerated reflexes. So we imaged his spine and we saw that there is a problem in the cervical spine as well as the thoracic spine. But he didn't have any upper limb symptoms at all. No upper limb symptoms. The thoracic spine showed an ossified ligamentum flavum in the thoracic spine. So we said we'll do a focal operation rather than doing a cervical operation. Though he had a C5-6 compression on the left side, he was completely asymptomatic for that with no Hoffman-Tromner's positive as well. And if you can look at the upper thoracic, you can see that the canal is completely obliterated at D12. So we did a simple D12 laminectomy. This is how bad he had gotten to just before the operation. You know, he could not even walk. He was almost wheelchair bound. And we did a laminectomy. This is the post-op scan. And you can see that sharp wedge of ossified ligamentum flavum that we removed.
Get up from the chair, lean forward,
And he was
put weight on the legs.
Okay 6 months later. This was the pre-op walking. And you can see the difference in him walking post-operatively. It's a big difference. So the point I'm trying to make with these cases is that surgery is not the big deal. I'm not talking about heroics or nuances of excellence in surgery, but it's decision making that we tend to get wrong sometimes. Because gait disturbances can mimic Parkinson's, can mimic atypical PD, can mimic NPH, can also present like this, and myelopathy can also present. So we need to do a thorough examination to localize the source. This is another patient with progressive low back pain. And if you look at her, she has a little bit of listhesis, but what's more debilitating is that she had low pressure headaches, progressively worsening low pressure headaches up to the point that she could not even sit up. She always had to lie down. And then we imaged the rest of the spine. We saw an extradural CSF collection around T12L1. You can see CSF egressing out of the spine extradurally at this level. It's very unusual, very uncommon, and you can see that the bone at L1 is also scalloped, something probably long-standing. When you do a whole spine screening, you can see the CSF seepage extradurally all the way up to C2. And this is ossified ligamentum flavum. And here on the right, on the left, you can see there's an outpouching of arachnoid. If we did a CT myelogram, an outpouching of arachnoid through which probably CSF was leaking. So we decided to do a laminectomy, and you can see this is cranial to the right, caudal to the left, and this bulge is actually dura that has been eroded by the thickened ligamentum flavum and constantly causing an egress of CSF. And we isolated the nerve root, tied the nerve root, sutured the rent, and her headaches were relieved 1 week after surgery completely. And this was a lady who could not even sit up for 5 minutes because of postural headaches. And this is an MRI 6 months later showing complete resolution. In fact, we published this on the cover of Journal of Neurosurgery Spine. The other thing that should not be missed out is subtle spinal cord lesions. This gentleman came with a progressive history of lower limb paresthesia and buckling of his knees, with a slight motor weakness and asymmetric examination of reflexes. On first glance, this MRI looks seemingly normal, but if you look at it in detail, you can see that there is a bulging over here, and the spinal cord is actually herniated ventrally, and you can see that and notice it by an enlarged posterior subarachnoid space. This is the corresponding axial view. So this is a spinal cord herniation. And since this guy had myelopathy, we decided to operate on him. And you can see how the spinal cord herniates ventrally through a rent in the dura. And you can lift it up actually and see that this is, redundant spinal cord. And we treated this surgically, put a piece of Duragen in front and put some fat, and this patient improved remarkably. So don't label someone as non-compressive myelopathy before you are sure that you haven't missed any subtle cord abnormalities. This is just about the second last case. 37-year-old male with quadriparesis and a right brachial plexus injury. We didn't have an option. We said, okay, we will do a cervical laminectomy and fusion. He had a few subtle hairline fractures on the CT. And we did a straightforward laminectomy and fusion. There was some improvement in his lower limb power, but that's not the point of this case. He had a wound soakage on the third day. And it was like this. It was like blood coming out. We were wondering whether it's infection, whether it's, it was just constantly oozing from this particular point. We said we have no other option but to go ahead and wash it out. We went back, washed it out, cleaned it, gave him some antibiotics. The culture didn't grow anything. We discharged him because it stopped. But he constantly said that there is something oozing again. So we readmitted him. And we wanted to see what was oozing. He said his dressing was getting soaked. And despite it being 2 weeks later, there was some constant ooze that was coming out from the wound. So we said that I think it's best, because the first time we did not find any bleeding source, we said let's do an angiogram to see if we've nicked the vertebral artery and that's caused something. And you can see that there is a pseudoaneurysm, not of the vertebral artery, but of the deep cervical artery. Whether that's related to the tip of my screw is a little difficult to tell, because on the CT angio, there was a 2 millimeter space between this lesion, but this is a deep cervical artery. It's not even the vertebral artery. It could be an anomalous artery. Anyways, there was a leak from there, and we coiled it. And after coiling it, we went back and re-explored the wound. to make sure that there's no residual blood that could get infected. We removed all those blood clots, and then the wound healed well, and we removed sutures after 2 weeks, and he didn't have any. So if there's any kind of persistent discharge from a wound where there is a possible vessel, please don't hesitate to do a DSA. And this is the last case that I want to lay emphasis on. This is a 45-year-old lady with breast cancer, had surgery, mastectomy, chemo, radiation, and had a routine follow-up of her MRI brain. She was told that she has a MET in the right thalamus, and at that time she was having some sensory disturbances in the in the left thalamus, and this was the lesion, and she was planned for radiosurgery, stereotactic radiosurgery of the lesion. However, she started having headache, vomiting, and weakness, and became progressively drowsy. She stayed close to our hospital, so she was rushed to our hospital completely unconscious. And with a dropping heart rate, rising BP, a Cushing's response, decerebrating, one pupil not reacting, and a right hemiplegia, we repeated a CT scan to see if this lesion has grown, and it had tripled its size in 1 week's time with severe edema. We did a decompressive craniectomy, removed the lesion after great detailed explanation, and it turned out to be a brain abscess, and it grew Klebsiella. We gave her 6 weeks of antibiotics, and she made a remarkable recovery. So her hemiparesis persisted, but she had perfect language functions, and she's due for a cranioplasty. So every ring-enhancing lesion in a known case of cancer is not metastasis. You have to be very vigilant about your diagnosis, and herein brings about the importance of tissue diagnosis. We don't know. If she came to us at the stage when it was 1 centimeter in size, we would have also probably thought that it's a MET. But never believe what a patient tells you his doctor said, because they usually tend to make up stuff in their favor. I would like to end with that.
Can you unmute Professor Turel, please?
Hello?
Yeah. Okay, you're heard now.
Okay. All right. So, very, very instructive kind of a series of cases which emphasis largely on clinical neurology, which unfortunately tends to get neglected significantly. We are still fortunate in India that we still pay some attention to clinical examination, but I still find lots of young residents just looking at the scan very hurriedly, looking at the patient's history and making a diagnosis on the scans. So treating the x-rays or treating the scans rather than treating the patient should never happen. And we frequently will see, as you showed in so many cases, brain lesion mimicking a spine problem or a spine pathology or a limb pathology, and vice versa. So, and again, we are fortunate that we understand clinical neurology, which the orthopedic fellows don't give you. If you have the orthopedic guys examining a spine, I'm not surprised if you would operate on a number. I've seen that umpteen number of times, a lumbar spine being operated when the problem is lying in the C-spine. So please treat the patient very assiduously, carefully, pay attention to the historical details, examine him very carefully, and yes, very rightly said, palpate the vascular tree, peripheral vascular territories very carefully. These missed causes of headache, we keep on seeing them again and again, and you already enumerated some. Colloid cyst is something which has been frequently missed, and these days patients come with a ready diagnosis themselves. They go for the scans even before the GP or the consultant can ask for. But it's a frequent cause of headache that I have seen in my practice in young females. But you showed something like sinus thrombosis. So yes, an acute hemiplegia may not be a brain problem, it can still be a spine pathology. So that's another lesson to learn. I think lots of beautiful lessons you taught us, Mazda, and I think you should present this once again on a larger stage. It is not only meant for Bombay Neuro Association or young neurosurgeons, I think there are lots of lessons to learn even for senior people. Thank you very much and congrats for a very...
Thank you, Professor Turel, and thank you, Mazda. Just a comment I would like to make on the same topic. The young neurosurgeons and the students should also not chase the scan, as to many times we chase the scan saying, how would we operate this patient? But it is also important to ask yourself another question. Could it be something else? Are we missing something else? So these two questions you have to answer yourself before you go for the final surgery. So one should ask, am I missing something? Could it be something else which is not seen on the scan? So that is very important in your training. So we shall move on to the next moderator, Professor Matthew Abraham, who will introduce our next speaker. Over to you, Professor Matthew.
Okay. First of all, let me congratulate Professor Vernon and JJ Hospital for organizing this program and Baxter for helping out. Dr. Prakash Nair has completed his MCS from SGPGA before joining as a consultant. Currently, he is an associate professor of neurosurgery in my department. He is the main endoscopic surgeon in Srijitra. He has done considerable work as an endoscopic skull-based surgeon. And I must say, as his supervisor for the last several years, he's a very meticulous surgeon with an instinct of innovation, and he keeps improving his technique with each surgery. And I'm sure he's the best person to be talking on endonasal endoscopic surgery for craniopharyngiomas. Over to you, Prakash.
Thank you, Dr. Matthew, for your very kind words. I hope I'm very well heard to all the participants. So, first I'd like to thank for this kind of invitation and for the Baxter team for putting all this together. So I shall be speaking on craniopharyngiomas with a brief overview of the disease itself and various technical nuances of the endoscopic endonasal surgeries that are carried out for these tumors. Now, embryologically, the pituitary itself arises from the Rathke's pouch, which is a ectodermally derived structure which invaginates off the floor of the roof of the nose towards the brain. This is led by the infundibular process that arises from the brain, and this process happens at about the 4th week of gestation. The Rathke's pouch is completely, the communication with the oral cavity becomes completely atretic by the 6th week. Now, the pars tubralis, which is the uppermost part of this Rathke's pouch, is very intimately related to the pituitary stalk. And this essentially describes how these craniopharyngiomas are so well related to the pituitary stalk and occur along this entire axis of the craniopharyngeal canal, along which it appears. Now, the clinical presentations are different in adults and children. While children more commonly present with symptoms related to raised pressure in terms of headaches or symptoms of hydrocephalus and visual loss, adults typically present with symptoms of visual loss and endocrinopathy, and the sexual dysfunction or amenorrhea and women. The other symptoms related to craniopharyngiomas in both adults and children can be hypothalamic dysfunction. And one of the aspects that we see are cognitive changes that happen in the adult. Histologically, craniopharyngiomas come in two different types, the adamantinomatous type and the papillary variant. Now, the adamantinomatous type occurs in two different age peaks. The first between the 5 and the 15 year of life, the second between the 45 and the 60th year of life. Now, the typical description of an adamantinomatous variant is that of a cystic tumor with calcification. And 90% of them tend to be calcified with enhancements in 90% and cysts in 90% of these patients. The CTNNB1 mutation that activates the WNT pathway is one of the findings that is seen in these tumors. On the other hand, the papillary tumors that happen more commonly in adults are typically solid with very sparse calcification. And this is one of these points which has been identified very commonly in these tumors. That's the BRAF V600E mutation. Radiologically, we've now, of course, long gone past the era when CT we had X-rays, and X-rays used to be taken for diagnosing calcifications between these tumors. On X-rays, these tumors appear to be typically solid with cystic components and have extensions along this axis of the pituitary stalk onto the third ventricle. The pattern of calcifications might be sparse, or there might be very dense calcifications which look like big stones in the pituitary fossa. Often you might have just a cystic tumor with a rim of peripheral calcification. And it's also not uncommon to see these large cystic tumors which are separate from the pituitary gland but have no calcifications within them. On MRI, typically they tend to be hypointense on T1 and hyperintense on T2. However, when they have these cystic components that contain a large amount of proteinaceous content, the cyst itself might be hyperintense on T1. And usually the solid component enhances very nicely on contrast. Now, essentially these tumors are heterogeneous in appearance, but the presence of lobulations and vessel encasement is more common for the adamantinomatous type of craniopharyngioma. The classification, craniophryngiomas have had various classifications, and one of the most accepted and the oldest classification of distance was presented by Yasagal in 1990. Various other classifications presented by Sami or other groups have been all variants of this original classification. They describe 6 distinct types. The first being tumors which are primarily within the sella, tumors which have sella but slightly supracellular growth, with the components being intradiaphragmatic. The type C, which is supradiaphragmatic. The type D, which has an intra and ventricular extension. The type E, which might progress to one side of the ventricle, and the type F, which is purely intraventricular with an intact floor of the third ventricle. From the endonasal perspective, this appears to be a more intuitive classification because the endonasal classification described by the Kassam group from Pittsburgh classified this in relation to the pituitary stalk, and the pre-infundibular variety of tumors occurred anterior to the gland, whereas the trans-infundibular variety occupied the entire stalk and extended into the third ventricle, whereas the retro-infundibular variety occurred predominantly behind the pituitary stalk, which was then arched forward. And the type 4 type, which was a purely third ventricular tumor. They later added another subtype, the type 0 to it, which was a purely stellar tumor. Now, factors that need to be considered before any surgical procedure for a craniophryngoma, especially through the endonasal perspective, include the lateral extension beyond the internal carotid arteries and the optic nerve. Hypothalamic involvement in terms of either obliteration or effacement of the hypothalamus on the sagittal view. The presence of calcification, especially dense suprasellar calcification. The location of the optic chiasm in terms of whether the tumor is predominantly in the retrochiasmatic plane or prechiasmatic plane. And the presence of hydrocephalus. Now, hydrocephalus is often a presenting symptom in more than 50% of children, either at first presentation or at the time of recurrence. And this needs to be addressed for any definitive management can be carried out in these children. And the main goals of treatment include the tumor control, salvage of vision, preservation of endocrine functions, prevention of hypothalamic dysfunction, and management of hydrocephalus as and when it might be seen. Now, from the transcranial perspective, these are very well-known approaches for craniophryngiomas. The transsylvian is probably a workhorse that has been utilized by a very large number of people. This is done through a perional craniotomy with skull-base extensions like the orbitozygomatic extensions carried out depending upon the extent of involvement of the tumor. Another approach that has been favored has been the anterior interhemispheric approach, with the opening of the lamina terminalis done to access the tumor present within the third ventricle. Subfrontal approaches either through frontal craniotomies or through supraorbital or suprabrocraniotomies are also very useful for dealing with especially tumors which are located in the pre-chiasmatic state. For purely third ventricular tumors, the transpilosal transventricular approach has been used. And there are descriptions, especially from Japan by Dr. Hakuba and Dr. Wahata, of the transpetrosal approaches for tumors, especially lying in the interpeduncular system. Now, the classical trans-Hilvian approach to the suprasellar system is crowded by a large number of structures, by the internal carotid artery, by the optic nerves, and the usual axis of tumor lies between the optico-carotid space or the interoptic space. And this involves brain retraction and dissection between these perforators. And also for lesions that progress more posteriorly, one needs to work in the vicinity of the third nerve, all of which might be compromised during the dissection. The endonasal corridor, however, provides a very direct approach to all these tumors. It avoids brain retraction, and the dissection occurs medial to these perforators. So the tumor gets debulked early, especially the cystic part, which allows the tumor to collapse, and the superior hypophyseal arteries are isolated very early on during the procedure. So comparison between various outcomes following microsurgery and endoscopic surgery show that while the extent of gross total resection for these tumors is relatively higher with the endoscopic approach, the clear difference comes when we look at the extent of visual improvement, which is nearly in the tune of 60 to 80%. And the extent of visual deterioration that occurs following the surgery, which is very low, which is less than 3%. However, this is offset also by the fact that endonasal approaches have a very high incidence of CSF leaks, nearly to the tune of 15 to 18%. So these are various cardinal differences that can be collated from literature when we compare microsurgical and now when we decide to proceed with an endonasal approach, the primary exposure is that of an endoscopic transtubercular approach. We use a right-sided flap. However, if we find that the right side is inconvenient, a left-sided flap might be used. It's always a vascularized nasoseptal flap pedicled on the sphenopalatine artery. We do bilateral wide posterior ethmoidectomy, a wide anterior sphenoidotomy with a posterior septectomy. All bony septations within the sphenoid sinus are drilled flat. This is not just for improving the instrumentation that occurs within this space, but is also for laying the nasoseptal flap very flat on the skull base. Then the bone is then removed laterally to visualize the cavernous sinuses on both sides, and the tuberculum cell is removed. There are surgical adjuncts like neuronavigation and carotid Doppler that help any surgeon perform this technique very well. So this might be what your skull base looks like when we first do our approach. And the important part of our exposure is this region of the limbus chiasmaticus. I think Dr. Sukhdeep had described how a part of bone removal just anterior to the tuberculum and just behind the plenum exposes this part where the chiasm lies. And essentially, the approach to the retrochiasmatic space lies between the optic chiasm and the pituitary gland. The lateral exposure has to include this component called the medial opticocarotid feature. This allows the surgeon lateral control beyond the lateral capsule of the tumor and allows early isolation of the superior hypophyseal artery. And this requires unroofing the optic canal a little bit on the medial aspect. Anterior extension onto the plenum may not be required for craniopharyngiomas, and even when the bone is exposed, the dura is usually not cut. When we do this part, this only causes unwanted herniation of the frontal lobe into the field. And this is the endocranial correlate. So this is what we would see from the endocranial perspective. This is the optic foramen through which the optic nerves come into the cistern and then join to form the chiasm. This is the area of the sella, and this in color green is the corresponding bone fragment that would come out when we expose the limbus chiasmaticus. Anterior to this is this blue coded piece of bone that would be the plenum sphenoidale.
So this would be what our bone removal would look like from the endocranial perspective when we do this procedure. And these are not absolute contraindications, but relative contraindications, and these could be lateral extensions into the Filbin fissure, where there are large cysts in the fissure, or where there are multi-compartmental tumors with large extensions into the posterior fossa or into the ventricle, and purely third ventricular tumors. However, one must remember that there is literature in the recent past where purely third ventricular tumors have also been accessed by the endonasal route. And the anatomical correlate here is essentially this space, which is the interpeduncular space. Now, this is the pituitary gland and the pituitary stalks, and all tumors lie in very
विठ्ठल मी एका वेबिनार मध्ये आहे तासाभराने फ्री
Hello, is there a problem?
Nice.
Prakash, you continue.
Yeah. So this is the pituitary stalk, into which there is, the craniopharyngioma have a great degree of affinity for involvement of the pituitary stalk and extension onto the third ventricle. So the important anatomical correlates involve this corridor in the retrochiasmatic system, in the retrochiasmatic direction onto the third ventricle, where we are met with by the basilar artery, which divides into the PCA, the PCOM. There is the lamina terminalis, which starts with the mammillary body and is attached to the dorsum, and this forms a membrane which prevents large extensions of the tumor into the posterior fossa. So I'd first give a case description of one of these cases. And the person was a 13-year-old female patient who presented with short stature and primary amenorrhea. She also had bitemporal hemianopia and presented with this large tumor, which is separate from the pituitary gland, which can be seen here. It's a large tumor with a very large cystic component, fluid level, and extends to the third ventricle. So, from the endonasal perspective, the first important thing would be a wide spinodox. The bone is filled and then removed using kerosene puncture. And when we get small bleeding from this anterior intercavernous sinus, we usually patch them off with surgically. The most important thing is this bone removal, which exposes the limbus, the anterior intercavernous sinus, and the stellar dura. And this allows the surgeon to cut this dura towards the optic nerve in this direction. And so you get this dural flap. Once the tumor has been seen, the surgeon has the option to directly decompress this tumor. In a cystic tumor, decompressing it, deflates the tumor and gives you more space. But also, this technique of surgery is essentially microsurgical dissection, where the arachnoid is meticulously separated away from the capsule of the tumor. In the interior aspect, one would see the PCA and the PCOM, which you will see very soon. This is the PCOM that now comes into view. This is the internal carotid artery. And another important anatomical adjunct that one must know is the location of the superior hypophyseal artery. Now, as I shall be describing later, the superior hypophyseal artery and its preservation is extremely important for salvaging good visual outcome that should be seen following tumor resection. Now, this is not typically a thin cystic wall that we see. It's a very dense fibrotic wall, and dissection requires sharp dissection with scissors and debulking using CUSA. Now, this is the right side where we again can see the stalk here, the PCOM, and the PC. That's very important to also meticulously dissect the perforators that arise from the PCA and the PCOM, because these perforators go on to supply both the diencephalon and the proximal part of the optic tract that can be seen here. Once all the vascular relations have been separated, the tumor is removed using a combination of CUSA and sharp scissors. And it's vital that one now comes to the part where the hypothalamic wall and the third ventricular wall is identified. And so once this tumor has been identified and this plane against the third ventricle here is distinctly seen, we can use a CUSA to debulk the rest of the tumor and remove. Again, instead of pulling, it's much easier to use sharp dissection to avoid traction injuries to these vessels. So at the end of dissection, one can see the fluorodeferred ventricle, the aqueduct, and the basilar bifurcation. So reconstruction here is done using a multi-layer technique with urogel fat. In this particular patient, we also use a piece of bone for reconstructing the skull base. And the keystone of repair is this large mesoceptal flap, which is used to cover this defect and is placed snugly at the. So this patient had a very uneventful recovery. However, she did have chronic DI following surgery. And at 3 months follow-up now, 3 months following surgery, the tumor showed no recurrence or no residue. And at nearly 1 year of follow-up, she continues to do very well. So the first important anatomical correlate that I wish to focus on is the location of the superior hypophyseal artery. Now, the superior hypophyseal artery in this lovely publication from Pittsburgh has been described to have 3 branches. The descending branch which goes on to supply the dura of the sella, and the 2 other branches, the infundibular branch for the stalk and the optic branch that supplies the chiasm and the optic nerve. Now, this branch can be sacrificed, and is often this sacrifice is required to mobilize the vessel away from the tumor. However, the optic and the infundibular branches need to be preserved. And this is an example where the superior hypophyseal artery, the descending branch can be seen, and this is gently dissected away. The second is the PCOM with perforators that supply the optic tract and the diencephalon, and thalamoperforators that supply the brainstem that arise from the basilar bifurcation and from the PC. So this is my second case, and this is a slightly different case in the sense that this is a stellar type, a purely stellar type tumor with extension into the suprasellar cistern, but looks like the diaphragm seems to be intact. However, there's a 2-year-old female child, and one can see that the sphenoid sinus is completely non-dilatized. Now, this would be a contraindication in the pre-endoscopic era, but with the endoscope and the presence of high-speed drills, one can really widely drill the sphenoid bone to get this wide exposure of the optic nerve, the part where you see the gland, and this area of the limbus chiasmaticus. The dura is carefully cut towards the optic nerve. One can see this motor oil-like fluid that is drained from these tumors when the cyst is decompressed. Now, once the cyst has been decompressed, the attention is then taken towards removing the capsule of the tumor. This capsule tends to be relatively hard, but one important adjunct is that one needs to be very sure of pituitary. Because the young female child, there are hopes that pituitary functions would improve following surgery resection. So the important thing to do would be to carefully dissect this tumor away from the wall, and at the same time, make sure that all these dural attachments are cut very meticulously with in a sharp fashion. Once the tumor has been adequately decompressed, the walls can be then removed. The contents tend to be typically calcified, and once done, the walls can be dissected away carefully. So at the end of the section, you can see the diaphragm and the pituitary gland at the back, and this defect is covered with a mesoceptal flap. So at 2 years follow-up, she has hypopituitarism, but once you see that the gland itself and the stalk itself has been preserved. This is my third case, and this is another important case to show why endoscopic approaches can actually address the root of the problem. So this patient had first presented 2 years earlier with a cystic tumor with areas of calcification more at the level of the dorsal. She had no vision in the right eye and had worsening of vision in the left eye when she was remissed. And while the tumor itself is not very large, you can see that this is entirely calcified. It's like a stone in the pituitary fossa with a cystic component. So the aim of the endoscopic approach is again, to get to the calcified part and resect it, because otherwise this patient will continue to have episodes of recurrences. Again, this wide exposure with drilling of the clivus towards the dorsal, which gets us closer to this calcified part. Once this dura is opened widely, almost up to the level of the optic nerve, the tumor can be decompressed. So the decompression is carried out in the fashion that we're all taught about: internal decompression first, and then dissection of the capsule later. But as we continue to decompress, one encounters this rock, which is absolutely hard and immovable. So then we go down to using techniques that we've all, learned while we've learned our microsurgery. and that is to use a bone fusor to try and decompress this part of bone. So a bone fusor is brought in, and we spent quite a lot of time trying to break this bone using the bone fusor. And as one can see, bone fusor is also it takes a lot of time and a lot of persistence to bring this down, shell this down. But in due course of time, this becomes mobile. The rock itself is separated from the rest of the tumor at the back, and slowly the third ventricle also comes into view. Once this is done and the rock is being mobilized, we bring it out into the field and then slowly remove it. So this lets us resect the rest of this tissue here within the cella and in the supracellular area, which is then resected with meticulous microsurgical technique. We try to remove all the microcalcifications. However, everyone knows that this is not physically possible. However, whatever can be removed is removed. We clean up the cellar floor and the edge of the diaphragma using, again, sharp tools. And at the end of this, the microvasculature that supplies the brainstem and the diencephalon can be sealed very nicely. So this patient now has a follow-up of maybe 2.5 years. She underwent post-operative RT, doesn't have a vision in the right eye, has continues to have good vision in the left eye. And this brings me to my last case, which is a transinfundibular type of phenylpharyngioma, which involves the entire stalk. And as can be seen in this patient has a large solid tumor involving the third ventricle with multiple cysts extending into the posterior fossa, onto the brainstem, onto the third ventricle with calcification. And she had presented to another hospital with features of hydrocephalus, and she underwent a VP shunt before she was sent to Citra. On evaluation, she was found to have bitemporal heliologia and hypopituitary. So once again, the crux of the procedure involves light exposure, where the dura can be opened so that the lateral part of the tumor can be identified, sharp incision of the tumor capsule, and identification of the arachnoid plane. The arachnoid plane and the identification of this in the lateral aspect allows the surgeon to see the superior hypophyseal artery, which can then be preserved. Here, because the stalk was involved, I go ahead and coagulate and cut the stalk right at the beginning. And this lets me dissect the part of the tumor which is in close relation to the lamina terminalis. So in this particular case, the lamina terminalis forms a barrier and prevents the tumor from going into the posterior fossa. This dissection again of the capsule slowly brings us close to the PCOM. So now we know where the vessels are at the back, and after this, one can then slowly dissect the rest of the tumor capsule using internal decompression using a fusor, meticulous microsurgical dissection to separate all the superior hypophyseal artery on the right side, which is being separated away. This is again the use of fusor for decompression. Now this tumor has been traced onto the third ventricle. So this is the margin of the third ventricle which is seen. And thankfully, this tumor doesn't have any attachment to the third ventricular floor. So using again, at no point is the tumor pulled. As the tumor is decompressed, it delivers itself into the field. Again, slowly separating this retrochiasmatic part, because dissection allows the tumor to come within the field, and the fusor allows the surgeon to decompress it completely. So the endonasal perspective also gives us a view that has been described by Dr. Miranda from Pittsburgh in a very privileged view. So you can see the entire third ventricle. And in patients where there is attachment of tumor to the third ventricle, one can also appreciate the fact that you might have physical infiltration of the ventricle which cannot be removed. So this patient is again repaired using fascia and flaps. So at 2 years follow-up, she continues to be hypopituitary, but has no other complaints. So complications of this technique include CSF leaks, hypopituitarism, diabetes insipidus, hypothalamic injuries, vascular injuries, vasospasm. This can occur in patients. We had one patient who had vasospasm on the 5th day and underwent chemical angioplasty and made complete recovery after chemical angioplasty. cognitive dysfunction and hypothalamic obesity, both related to surgical and radiation complications that follow surgical resection. And just to give an overview of what long-time complications might be, so there might be tumor or treatment-related complications of progressive disease recurrences, cerebrovascular disease due to radiation, chronic neuroendocrine deficiency, non-alcoholic fatty liver because of hypothalamic obesity. And just to give you an idea that their mortality is nearly 3 to 9 times more than the average standardized mortality, with cardiovascular mortality being the most common form. So to conclude, the intranasal corridor approach gives us a very direct view for approaching the sickle cell anemia syndrome. And the endoscopic approach has been associated with better visual outcomes. This is because superior hypophyseal artery preservation leads to better visual outcomes that occur following surgery, and meticulous reconstruction of the skull base is necessary for preventing future failure. Thank you. Thank you very much.
Thank you, Prakash, for an excellent talk. I'll just make a comment. Let's say craniopharyngioma is such an amorphous category. So, you require a lot of armamentarium to tackle it, different approaches, a whole lot of tools. And the variation is actually not just in its location, but in its consistency and type of attachment. And I must say, if the attachment is loose, the dissection becomes a pleasure. But when it is tight, fused, or perhaps a replacing type of attachment, then the dissection becomes a pain. And you need tremendous painstaking effort to get a good outcome. And perhaps more than just removal of the lesion, the outcome depends on how meticulously you have preserved the hypothalamus. I don't see that there are any more questions in the question box. Any more questions? If there are no more questions, thank you, Dr. Prakash.
Thank you very much. Thank you very much.
Matthew, am I audible?
Yes. Thank you, Professor Matthew and Dr. Prakash for that presentation. And just for those who are hungry, who want to pick up their lunch, they can bring their plate along, serve their lunch, and come and join us for the next talk, because it's a very interesting talk, especially from the point of view of exams. Many times I've seen when a question is asked on epilepsy surgery, many things are not written properly. So most of the time it is either a short note or it might be a long note also nowadays. So I would request Dr. Suresh Sankla to come in and introduce our next speaker, who will clarify certain doubts, and also it would help the students to write the theory in the theory exams. Over to you, Suresh.
Thanks, Vernon. Thank you very much. It is indeed my pleasure to introduce Jayesh, one of our younger and very bright colleague from SGPGI Lucknow. He is presently working as an assistant professor at SGPGI. He has been trained at SGPGI, and after his MCH qualification, he did some very important postdoctoral fellowships, particularly in neurosurgical oncology, in pediatric neurosurgery, as well as in minimal spinal surgery and epilepsy surgery. And he visited several places in India and Japan and Seoul to have himself educated in these branches. He has been credited with several honors and awards and a lot of publications, and he has in fact edited 2 of books published from SGPGI. So it is my great pleasure to introduce Jayesh Sardaha. Jayesh, over to you.
Your kind word. Am I visible? And what my slide is? Yes. So thank you so much. I'm very grateful to Dr. Velho and his team for providing this opportunity. As intimated by Dr. Velho, this is basically specially prepared for residents, because it's very difficult to cover all about the epilepsy surgery in 25 minutes. but I have made some basics about the epilepsy surgery. And today I would like to discuss what is the drug-resistant epilepsy, when to do epilepsy surgery, basically a phase-wise pre-surgical evaluation of the epilepsy, and at last how to do it. So we'll give a very interesting case presentation, and then we'll give a brief overview of all the steps of the epilepsy surgery, mainly the important one. So before I move ahead, especially thanks to Dr. Matthew sir and especially Dr. George, because I trained for epilepsy surgery under him, and thanks for providing the tips for epilepsy surgery. So what is a definition of drug-resistant epilepsy? Because there is so much confusion about that. So just clarify, the International League Against Epilepsy of 2009 very clearly defined the drug-resistant epilepsy as a failure of adequate trial of two tolerated and appropriately chosen and used anti-epileptic drugs scheduled. So whether you use a monotherapy or in combination, but the two is important till you achieve the sustained seizure freedom. So what is sustained seizure freedom? When you consider your patient is a seizure free, according to ILE, should be very clear that seizure free minimum seizure free period should be 1 year, or as a periodic seizure separated by period of 3 times the longest interval between the seizure prior to the treatment. So it means, suppose in preoperative, your epilepsy patient have a frequent seizure, but the longest period they have a 6 months. Then after a conservative surgery or the epilepsy surgery, your patient will be considered seizure free if there will be a no seizure for 18 months or minimum 1 year, whichever is longer. So it is very clear. Now, despite of all the newer anti-epileptic drug, still 30% of patients have usually drug resistance, which may be amenable for the epilepsy surgery. Broadly dividing the temporal lobe epilepsy and extratemporal lobe epilepsy. Compared to the extratemporal lobe epilepsy, temporal lobe epilepsy have a higher incidence, better surgical outcome, and the most common example we all know is the major temporal sclerosis. So I would like to particularly introduce this, describe this trial, because this was a trial published in 2001 in the field of epilepsy surgery by Webb et al. And it got a real revolution in the field of epilepsy surgery, because this was a study in which first time they have found 58% of the epilepsy patients had improvement after surgery compared to 8% after conservative treatment in temporal lobe epilepsy patients. So the conclusion was that in temporal lobe epilepsy, surgery remains superior to prolonged medical therapy. And after this study, all the temporal lobe epilepsy surgery shown that the early surgery is always better than the late surgery. So coming to the pre-surgical evaluation of the epilepsy, it's very common, and I try to make it very simple. The objective of the pre-surgical evaluation phase-wise is to pinpoint the seizure focus. Means lateralization means out of the two hemispheres, where is the onset of the seizure is lateralization, and out of the one hemisphere among the various lobes, exactly where is the pinpoint focus of the onset of seizure is situated in one of the lobes. That is localization. So first goal is to pinpoint the seizure focus. Then after you pinpoint it, you have to find the function of that epileptic zone, whether it is functional or non-functional. So that can be done by brain mapping. And third is very important, that is you have to select the right surgical procedure to maintain a balance between seizure outcome and deficit. So these three things can be decided by phase-wise pre-surgical evaluation, which can be broadly in 3 phases: non-invasive, invasive, and third is in the OT, that is a intraoperative monitoring guided surgical resection. Now it is very important to understand that every surgical patient, epilepsy surgical patient doesn't require to undergo all the phases. So phase 1 is 70 to 80% is more than enough. Very rarely phase 2 or phase 3 is required. So every epilepsy surgery patient, the most important is semiology, the history we called it. So depend on the part, the motor or sensory or whatever. especially by the neurologist, you can lateralize or localize it. Then patient underwent EEG, then continuous video EEG. For continuous video EEG, so we try to provoke the seizure by either withdrawal of the drug and then gradually stop the drug, or by certain measure. Then we minimum monitor the 3 seizures under camera. Not only explain the lateralization, proper localization, but also it excludes that there are various differential diagnoses, whether it is a seizure or non-seizure. Then patient should underwent the epilepsy protocol, especially under the various sequences of MRI, and then neuropsychological evaluation to determine the cerebral dominance, the level of verbal as well as visual memory, and language issues. So now after this semiology and MRI and video EEG, if in the MRI, if you see the proper focus, or say suppose in the right frontal or right temporal lobe, then it is known as a substrate directed seizure. Now, if you see if your MRI focus and your semiology and the video EEG lateralization and localization are the same, then this is known as a concordance. So the advantage of concordance is the patient is directly amenable to epilepsy surgery if everything is fit. And measure of the patient, it remains concordant. Now the problem is when your epilepsy patient is MRI is normal, or there is a discordant or non-concordant between the semiology finding, video EEG, suppose they show the frontal, but the MRI suggests you temporal lesion. Then you may require a further functional imaging procedure like functional MRI, ictal SPECT, PET scan, magnetoencephalography, or WADA test. So this typically helps to not only exactly precisely pinpoint the lateralization or localization, but it will also help that the seizure is coming from right side or left side, which are the functional area and non-functional area, what are the dominants, and what could be the probable neurological deficit. Now, this is the 80% of case, this would be the enough to decide that patient will require epilepsy surgery or not. But rarely, if still you are not able to decide that the lateralization, localization correctly has been happened, because of maybe diffuse lesion, maybe bilateral lesion, maybe multiple focal lesion, then this one is a non-congruent data. Suppose I take an example like bilateral MTS, and you don't know which hippocampus is responsible for the drug-resistant epilepsy. So phase 2 is required for that. That is an invasive EEG, in which we use certain types of electrolyte. For example, these are the depth electrolyte. So what we do, we introduce the depth electrode with the help of serotoxin to both the side of hippocampus, and then we shift to the video EEG room, where then we monitor the 3 seizure the help of camera, and then under the video EEG, we precisely localize which hippocampus is responsible for the drug-resistant epilepsy. This is also known as stereoencephalography. Suppose your lesion is diffuse and non-congruent, but it is surfacing to also involve the dominant cortex. Then sometimes we do craniotomy. We put a kind of this grid electrode or the strip electrode over the cortex, and then again patient shifted to video EEG room, and then we lateralize and localize precisely that what to be removed and what not to be removed. Now finally, after all those phases, epilepsy surgery patient management conference is there, in which all the subspecialty person, which is part of epilepsy surgery team. For example, we have 2 neurosurgeons, me and my senior colleague, Dr. Anand Mehrotra, and we have 2 senior neurologists, neuroradiologists, nuclear medicine specialists, neuropsychologists, neuroanesthetists. Why all this required? Because you have to decide the 2 things, whether patient requires surgery or not, epilepsy surgery or not. Second thing, you have to see for the risk-benefit ratio that about the seizure outcome and possible neurological deficit, so you can decide about quality of the life of the patient at the end of the surgery. So now this is very important slide, because once you are clear that patient require epilepsy surgery and your patient is also ready, but what to do? How you decide that what kind of option? So you have 3 options: resection surgery, disconnection, or the stimulation. Now when to do what? If you're in all the phase-wise simulation, if you are very sure about the focality, and the lesion is very small, and particularly suppose AVM or dealing with the tumor or cavernoma, and then with the help of intraoperative EEG that we also known as ECOG, and you remove the focus, then it is known as lesionectomy. This is also a phase 3 kind of evaluation. Under evaluation, you do lesionectomy. Now, if your focus is situated in the mesial temporal lobe or the medial temporal lobe, then you have two options: anteromedial temporal lobe resection (AMTR) or selective amygdalohypocamptomy, because it is seen that the mesial temporal lobe, which is a part of limbic system, is mainly responsible for the drug-resistant epilepsy majority of the time, the temporal lobe. Now, amongst the two, all the literature has suggested the equal seizure outcome after two, but on comparison, the selective amygdalohypocamptomy has a clear-cut better cognitive outcome compared to MTR. Now, the problem lies where you, with all the phases, you have a multifocality or the lesion is diffuse, but still you got very clear idea that the lesion is on one side, right hemisphere or left hemisphere. Then you have two options: either you do a hemispherectomy or a multilobar resection, which become obsolete now because the hemispherectomy means hemispherectomy is obsolete nowadays because it was linked with extensive morbidity and mortality due to hemispherosis. Now people are doing functional hemispherectomy where they preserve all the cortex, basal ganglia and thalamus, but they disconnect the corona radiata connection, white fiber connection from the basal ganglia and thalamus to all the peripheral frontal cortex. Suppose your lesion is bilateral and diffuse, and you are not able to define the focus, then the corpus callosotomy is a palliative disconnection procedure to a very good role, mainly 70 to 80% outcomes, especially in atonic seizures. With very subtle surgical outcome, but yes, it's very important if it is lying in the eloquent cortex. And if you are not amenable, suppose the motor cortex, you're not amenable to exercise of the motor cortex. In that case, you can use this rare procedure as a multiple subpal transection. Yes, you can have a more than 50% surgical outcome. Now, at the end, suppose very rarely, but non-localized lesion, generalized syndromic kind of things, you are unable to dissect or unable to disconnect. And recently, this two terminology, vagus nerve stimulation and DBS for epilepsy, is very known. And all the literature says that the 50% of the patient, 50% of the seizure outcome can be seen in the 50% of the lesion. So that is all about the VNS and the DBS. So this is kind of our experience. I'm not going to in detail what we are also a beginner in this stage. Just I would like to explain some interesting case example of different surgeries so that all the residents can understand how we do all kind of different with all the steps. So it's a 22-year male with a focal seizure with secondary generalization since 8 years. He was in various drug but drug resistant, and finally the seizure came for more than 2 per week. All the data shows localized to right frontal area. And the lesion is, as we can see, it's a non-enhancing. Most likely we could see it's a DNET or maybe focal cortical dysplasia. And we suspected in patient underwent the surgery and the right frontal lobe is exposed. As we used this intraoperative photography, EEG, and the great electrode are placed. This is the lesion. And initially we excised the lesion, but we can show here that the EEG shows that interestingly the focus was coming from the frontal pole, not from the tumor. So still seizure was persisted, or the sharp wave was persisted. Then we remove both tumor and the focus, that is also the frontal pole, and the seizure sharp wave were disappear. And patient had no seizure, good follow-up, 4-month follow-up, and patient had no seizure, and pathology was DNET. So this was basically lesionectomy that I would like to explain. So another interesting surgery of which is suggested most common amongst the epilepsy surgery, that is lesionectomy and anteromedial temporal lobectomy or the amygdalohypocamptomy. So this is the So this is a 28-year patient with 28-year male patient with complex partial seizure history since 12 years without any deficit, and a neuropsychological assessment suggested that all the language and verbal memory was intact. And I would like to show you how, with the help of video EEG, we do lateralization and localization. So I would like to show you the classical complex partial seizure, how it would like to look. So it starts with the behavioral arrest. That was classical aura of complex partial seizure. We can see at with the left hand, patient is doing abnormal nose wiping from the ipsilateral hand, that is from the left hand. That is very classical of complex partial seizure. And then we see the pill rolling movement from the right hand, that is a motor automatism. Clonic movement of right lower limb. And patient also had some frequent in-blinking. So the contralateral upper limb and lower limb clonic movement and ipsilateral nose wiping is very classical. Then we can see that the contralateral head turning, if it is early, then it is a frontal lobe. If it is a late, then it is a temporal lobe. So late thrust on the opposite side followed by seizure generalization is classical of mesial temporal lobe. So opposite side is left. So ipsilateral things and left side contralateral motor automatism and the opposite side head thrust all suggestive of left mesial temporal focology. And this is the video EEG of the same patient that shows the slow waves alpha arithmetic activity at the temporal region followed by generalization. So all the phase-wise investigations suggestive of left side. Now this is the MRI. It's a classical of MTS. You see the prominence of left temporal. This is a triad of MTS. Prominence of left temporal horn, hyperintensity of the hippocampus with the atrophy compared to right, and on the volume analysis, the sequence shows the left side volume was less compared to the right side. So classical triad of the left side MTS. Now we plan for MTF. Now the position is very important. The left side temporal anatomy is planned. Now in this position, we see the 50 degrees head rotation is important towards the right side because you want to make your temporal surface parallel to the ground. And then another requirement is 10 to 15 degree head extension because it makes your hippocampus vertical to your vision. So you can excise a very en-bloc way and facilitate the en-masse excision. Then the frontal lobe, temporal lobe, and sylvian fissure. And then because it's the left side, so we choose a 4 centimeter from the tip of the temporal lobe. On the right side, we use 4.5 centimeter. And the line of resection is important. This line of resection is always parallel to the T1 sulcus or the superior temporal sulcus. And then is the 8th sig going medially because we have to spare the left superior temporal gyrus. The lower portion is going to down up to the skull base. The temporal neocortex part involves the middle temporal gyrus, inferior temporal gyrus, and the part of the superior temporal gyrus. So the first step is the temporal neocortical excision completely. Then the second step is identification of the temporal horn, and for that the tip is from the 3 centimeter from the posterior to the temporal tip and 3 centimeter deep at the superior temporal sulcus, you find the temporal horn. And this anatomy landmark, temporal anatomy landmark is very important. This is anterior, this is a posterior, lateral, medial. So this is the classic structures at the temporal horn. Ventricle is the hippocampus, is the collateral eminence. Medially, because the roof of the temporal horn, this is the amygdala. Here, the medially, this is the uncus, and this is the choroid plexus and the choroidal fissure here. So here will be here is the inferior choroidal point. Now, your plan is basically a en-bloc hippocampal excision. So for that, there are steps: a medial disconnection first, then anterior disconnection between the hippocampus and the amygdala, and then later disconnection at the collateral fissure. So because you need a two specimen, one is hippocampus, second is different amygdala and uncus separately. So first you excise the hippocampus separately. So for that, the most important part is you start with the choroidal fissure and choroid plexus always remain supinely. Then you elevate all the complex, the hippocampus and parahippocampal gyrus. Both are the complex because you see the hippocampus and dorsolateral parahippocampal gyrus. So it should remain supinely, pia should be intact to prevent the injury to the third nerve as well as PCA. Now the most important part, when you dissect it, you should elevate it from medial to lateral and anterior to posterior. Now, so once you reach at the posterior 1/3, there are some branches, the hippocampal artery from the PCA, which is going into the hippocampal sulcus here. So it should be coagulated and can be sacrificed, but exactly at the hippocampus sulcus level. So you should prevent the injury to the PCA. Why I'm going to detail of the procedure on every step, because this is the 80% of the epilepsy surgery. So parahippocampal gyrus, which is about to be sucked. And then this is also important, where to transect the hippocampus posteriorly. So there are 3-4 criteria. One, either you cut it at the 3 cm from the tip. Second, where it turns, it becomes a hippocampal tail, and where it is crossed, it is turned to the brainstem exactly at the collicular plate. Or third, you use the intraoperative monitoring, where you cut exactly when the seizure discharge being stopped. So you separate the hippocampus and it excise and toto. Now the second step is uncus and amygdala excision. Now amygdala, basically it is a ill-defined structure, but you have to remember that it is a two-part, ventrobasal and dorsomedial. So dorsomedial is always embedded inside this globus pallidus and optic tract, so it always will be preserved. But where do you stop? So there is a practical line known as a Vance line. So from the IC bifurcation to the inferior caudal point, both are the visible structure. You should always remain below it and anterior to it. You should all the structure till you see the pia of the brainstem. Those is enough for the uncus and part of the amygdala excision. This is complete the surgery. This is a 2-year follow-up of the patient, and still patient is completely drug-free and the seizure-free. Now, another important question mark or the controversy is once your structure, once your medial temporal tumor, when it is situated medial to collateral sulcus. So what you want to do, whether you will excise the lesion only, or you would like to excise the lesion plus amygdala hippocampus. And all the literature till date suggests that if your lesion is lying medial to collateral sulcus, then it is always better to excise the amygdala as well as hippocampus along with the tumor. So for that, I use this selective age approach. In this child, this is an 8-year child with complex partial seizures in 3 years, all the drugs, but it was drug resistance. This was the tumor, T1 hypo, T2 hyper, ill-defined contrast enhancing exactly at the floor of the temporal bone, partially embedded in the hippocampus. So probably it was, I thought it was a DNET or glioneural tumor, some kind of low-grade glioma. So the plan was the transcercal, the middle temporal, superior temporal sulcus approach inside the ventricle, and then finally both tumor excision as well as amygdala and hippocampus excision. Just a small, very small video. So that is the advantage. If you spare the temporal neocortex, so the cognitive outcome would be better. So plan was to transcercally want to enter in the ventricle. This was the tumor which is lying laterally on the collateral eminence, but partially embedded the hippocampus. This was the hippocampus which was lying separately. So I excised the tumor completely, and then this was the hippocampus separately. And you should excise the hippocampus by the same steps as already I described. First medial dissection, then lateral dissection. So this was the brainstem. The pyometer was intact. The branches of the PCA is the hippocampal artery at the hippocampal sulcus. And find first hippocampus and then uncus and amygdala was excised. So end block excision. And so we see the temporal neocortex was spared in this approach. So the idea is basically the biopsy was a ganglioglioma grade 1. The patient head was seizure-free, better improvement. And the final slide of the surgery is a disconnection surgery. Here, just I would like to give the idea of what are the steps of the disconnection surgery. By this patient, a 7-year male child, and he had refractory seizure since birth. And finally, when he came to me, he had a daily 5 to 6 episodes of seizure per day. Sorry for that music. So, as patient had a daily 5 to 6 episodes of seizure, patient was mentally retarded, only able to say only a few utter words, and patient had right side hemiparesis. All the phase evaluation suggested of the left side hemisphere as a focus, and this was the MRI. Had a porencephaly left side complete atrophy and gliotic area around the porencephalic cyst with atrophy of the cerebral hemisphere. So in this kind, we had only one option with all the consent. We went for, there are two options either for the disconnection. Either we can go from the peri-insular hemispherotomy, peri-insular functional hemispherotomy, or transventricular parasagittal hemispherotomy. So basically, what is hemispherotomy? You want to disconnect the two cerebral hemisphere with the help of complete pterostomy, and you want to disconnect all the internal capsule and coronal radiata from all the cortex from the basal ganglia and the thalamus. For that, you require anterior disconnection, theoretically from anterior cerebral artery to the temporal horn or the Sullivan fissure, that is anterior disconnection, from surface to the anterior skull base. The middle disconnection is just later to basal ganglia and thalamus inside the ventricle. You connect from the connect the Sullivan fissure to the temporal horn. You deroofing the temporal horn completely till atrium. So this is the middle disconnection, and posterior disconnection is you disconnect the skin from the atrium. And finally, you do amygdalohepectomy and temporostem transection. So these are the steps will be helpful for the resident. And just fastly, 1 minute, I would like to go through the steps just so that they can remember. The parasagittal craniotomy, half anterior, half posterior of the coronal suture. You may remain 1/3 or 2/3. The interhemispheric approach till you reach the corpus callosum, very whitish shiny structure. This is the anterior cerebral artery going inside, curved inside. The geno corpus callosum easily can be identified. So it's very important to identify the geno of the to the splenium, all the corpus callosum, the body of the corpus callosum. Then via corpus callosum, you reach the lateral ventricle frontal horn, so you can identify all the ventricular structure, basal ganglia, thalamus, and then you start the corpus callosotomy from posterior to anterior. So it started with the splenium. You divide all the corpus callosum fiber at the end with the posterior body of fornix. Here, and posteriorly you want to reach at posterior quadrigeminal system till you see the vein of Galen. So finding of probably a landmark for the posterior hemisphere or posterior commissure. I hope my slide is visible, Vello sir. So, Vino Galen.
Yes, go ahead.
Yes.
Can be seen.
And then colostomy, then start with the splenium, then the body, and then anteriorly at the genu of corpus. So you start with the genu and then you reach the rostrum, then you find the anterior commissure. So basically your plan of corpus colostomy from genu to splenium completely, and then you find the anterior commissure and then you cut it. And then this is the site of anterior basal disconnection. You remain just anterior to the basal ganglia till you reach lateral part of Sylvian fissure from the ACL, and till you reach the pia of anterior skull base. Then the middle disconnection is inside the ventricle. You remain the thalamus, so lateral to the thalamus. From atrium, you want to go ahead. This is the forencephalic cyst. So you should always define the glenotic area and you should always remain medial to it while doing disconnection. So idea is just a de-roofing of the whole of the temporal horn. That is basically a middle disconnection. So we identify the temporal horn. This is the classical hippocampus. Then the posterior disconnection, the basal ganglia thalamus, middle disconnection, with the splenium till you reach atrium completely. And the last step is temporal transection, or the hippocampus transection. So this is the hippocampus. You are transecting at the posterior 1/3 area, and from transventricle, from the superior, you can do all the megalotopy via the ventricle. So the final steps, you confirm the complete disconnection, anterior disconnection from ACA to lateral Sylvian fissure, middle disconnection, you deroof the whole the temporal horn, and posterior disconnection from splenium to the atrium. So finally, this was completed, and the patient, the power and language was remained same because it was just a 7-year child. There had a great chance of plasticity of the brain. But interestingly, the seizure was completely reduced, and he had only 2 episodes of seizure since last month instead of daily 6 episodes. So here I would like to end the things that 30% of epilepsy patients are drug resistant. Half of these patients are potential candidates for the epilepsy surgery. Early referral is especially important in childhood epilepsy because the great chances of plasticity and excellent seizure outcomes, especially in pediatric epilepsy. With proper preoperative evaluation, one can achieve very good seizure control, especially if phase 1 is enough for everybody. And epilepsy surgery is obviously a teamwork development. Thank you very much for attention. Thank you, everybody. Thank you, Suresh.
For this wonderful lecture, and yes, you said very correctly. Epilepsy surgery is a teamwork, a real teamwork, and the key to success includes a good localization and diagnosis of the problem, also the selection of the right patient, and the appropriate surgical procedure that is required for the success of the epilepsy surgery. Do we have any question for Jayesh? I don't see any question. Vernon, do you have any question for him? I don't see any question on the question answer section.
Sure.
Yeah. So
anyway, in that case, thank you very much, Jayesh, for this wonderful lecture. And
thank you, Sagla, sir.
Yeah.
Very nice described. Thank you very much.
Thank you, Jayesh.
Back to Vernon.
Very elaborate presentation, and I hope the students have got their concepts clear about epilepsy surgery.
I hope to.
Yeah.
Can I just make a simple comment?
Yeah. Make
Vernon, it was it was a very well planned lecture, actually. I would say very well executed operative procedures. And Dr. Jayesh, you are very humble, polite, very humble in your presentation. Such a good work you have done in a very humble way. Thank you very much for this beautiful.
Thank you so much for that blessing word, sir.
Thank you. And now
Thanks.
we shall go back to Dr. Sukhdeep, who is going to show us some beautiful anatomy dissection slides. And we'll then have Dr. Sunit Jindal, because they are important slides. And I think we should not miss that opportunity to learn. So, Dr. Ketan, is he there? Ketan Desai?
Yeah.
Please take over.
Yeah. Sukhdeep. Hello, Sukhdeep. Is he there?
Still not connected, it looks like.
No, sir, he was connected. He's already on. Sukhdeep, is there?
He was connected, sir, but I think we lost him again. Yeah, sir. Yeah. Now he's on the panel.
Yeah. Sukhdeep, you are there?
Sorry. Yeah. Yes, sir.
Sukhdeep. We can see him.
Yeah.
Sukhdeep, you are there? Hello. Yes, Sukhdeep, you can start your presentation.
Sukhdeep, you may start your presentation.
You can start your presentation, Sukhdeep.
Yes, sir. Sharing my screen. It's connecting. Can you share my screen?
We can see your screen.
Okay, just a moment. Yeah, no. So I hope now, can you see my cursor also?
Can't see the screen, your slide. Yes.
So can you see my cursor?
Yes, your cursor is bigger now.
Okay, thanks.
Go ahead.
Thank you. So coming back, I think where we left, I think we had a very unfortunate power cut. So this is the sella here. Then we have the cavernous sinus, part of the medial cavernous sinus, and then we have these carotid arteries beautifully going, forming a C-shaped curve, and then we have a vertical part here. So this is just a close-up view. Once you remove this sella, you see there is a large venous spaces between the layers of the dura. These are your basal plexus around the clivus here. Then we have this communicating with the cavernous sinus here. Then we have anterior cavernous sinus communication here, which we have to be careful when we are removing the bone around chiasmatic sulcus or the planum. So you may have to be careful not to injure this area. So this is just the overview of the dissection. So I'll just skip this part. So coming to the median nerve, of course, median nerve I showed you in the microscopic anatomy. Now you can see have a endoscopic view. Here is the median nerve going towards the foramen lacerum. Median nerve again is formed by the joining of nerve to this greater superficial petrosal nerve and the deep petrosal nerve. So they join and form the nerve to be this median nerve or nerve to pterygoid canal. So this is the nerve to pterygoid canal. So this is basically the foramen lacerum. This is the nerve which enter foramen lacerum near the anterior band of petrous ICA. So you can see this is inferior to the band of the ICA. So this is the landmark here. So this is the median nerve which has been like dissected all around. Of course, there is bone and everything around here. This is the sphenopalatine ganglion, which is more anterior towards your screen, and behind you can see this median nerve is going to the petrous part of the internal carotid artery. So both sides we have now the median nerves dissected. Then it is going to the petrous. From petrous part you have this vertical segment, which is the paraclival or the clival segment of the ICA, and once it enters the cavernous sinus, here is your sellar part of the ICA. So now you can have a better view. This is the paraclival ICA here on the both side. Of course, the paraclival is related to your petrous apex here, and these structures which are related to petrous apex, they will be coming into picture. So once you remove the venous injection from the clival aspect, you see these arteries which are supplying the clival dura. These are supplying the Dorello's canal. These are also supplying your sixth nerve. So these are all branches of your cavernous ICA. So we have to understand cavernous ICA has mainly two trunks. One is meningohypophyseal trunk. One is inferolateral trunk. So meningohypophyseal again has three branches. So from the name you can understand meningeal branch, hypophyseal branch, and one is tentorial branch. So this hypophyseal branch is inferior hypophyseal artery, which is coming into the picture here. If you can see, this is the inferior hypophyseal, and then you have the dorsal clival artery. Here you can see beautifully how this artery can be a source of bleeding when you are doing some paraclival approaches. Of course, you can see here it is supplying a branch to the sixth nerve also. So this is the Dorello's canal here. This is dorsal clival. This is inferior hypophyseal artery. This is on the opposite side. So this inferior hypophyseal again is a branch of meningohypophyseal trunk. This is how the sixth nerve is supplied by the dorsoclival. If you see, this is the Dorello's canal. This is the ICA here. So this is a little angled view. And you can see this tie-shaped ligament here. This is a ligament which is here attaching to the sphenoid here, and it's going to the petrous apex. So petrosphenoid. So this is basically your Gruber's ligament from endoscopic point of view. This is Gruber's ligament, and below it passes your sixth nerve on the way to the cavernous sinus. So we tried drilling cavernous. This is the petrous apex here. So this is the sixth nerve. Now you can see it has a very steep course. It arises at your pontomedullary junction, and it takes a very oblique course all the way to through all these venous spaces. There are large venous gulfs are there. So you can see this sixth nerve going like this to the cavernous sinus. So this is the first part of presentation. Coming to now the second part, which is our main concern with so coming to sella and cavernous sinus region again. So this is here. I hope everyone can see my cursor. Some people are having problem, but let's see. So this is the sella. Once you remove the dura over the sella, then you see the pituitary with its capsule. It's here. Venous congestion, venous injection from cavernous sinus has been removed partially. So we can see a branch directly coming from ICA supplying the capsule here. So this is basically McConnell's capsular artery, which you must have read at in the Roton textbooks. Of course, these are direct branches. They are grouped into anterior and inferior. And during their microscopic dissection, they found it to be present in 22 to 30% of specimens. But with more of people doing now endoscopic dissection, they are more commonly found. Of course, it's better seen on endoscopic views. And sometimes people can encounter during surgery that there was some bleeding from some branch which we were not able to clearly see. Of course, this can be a source of bleeding, but they can be taken up, coagulated without any problem. So McConnell's capsular arteries are here going straight. Again, this is your sixth nerve in the background with dorsal clival artery. And if you see the posterior pituitary, there is a branch going which is supplying the posterior pituitary, which is
There is some problem with his connection again.
There is.
Yes, sir, I think
yeah,
yes.
Yeah, it's come back. Power has come back. Yeah,
Okay.
He'll join. Shortly.
in WebEx, Vernon. What is happening is if you are disconnected and rejoin, then it takes some time. Strange.
I'll just try to call him and ask him what is the problem.
He's having a power issue because I think the power has got cut off. Yes, so I think we'll just wait till he
I just phoned him, Vernon.
Vernon, let's have the last talk. And by the time if his power comes back, we can take him.
Sir, he's joining in couple of weeks, sir.
Okay.
While we are waiting, it will be a humble request to all the participants. There is a link for feedback in the chat box. If you can click on that and share your feedback, that would be nice. It will be done in less than a minute. Thank you.
Ganesh is re-logging. Do you get some information?
I spoke to my colleague who spoke to
No, I phoned him up. He said that there was a power cut. The connection has again come back, so he's trying to log in.
Okay. Yeah, I'm checking, sir. Now, and yeah. Now he's on the panel. Yeah.
Yeah, Sudeep, start. Yeah. Yeah, you can start. Yeah, Sudeep, you can start.
Yes. Yeah. So here we have the posterior pituitary and some part of these vessels going. So in this, you can see there is this inferior hypophyseal artery which is supplying the posterior pituitary. And this is the view here. Now you can see this is the optic nerve. We have some part of ophthalmic artery visible. This is the opticocarotid recess. This is the angled view of the lateral wall of sphenoid sinus. Of course, this is the medial cavernous region and this is the lateral cavernous region. So here we will have our lateral cavernous wall, all these structures which are lateral to the ICA, which are relevant if you are trying to do sometime very extended approaches. Even then, we have to understand this anatomy, so we are familiar. So this is a beautiful view of the inferior hypophyseal, how it is arising from the posterior aspect, or you can say the vertical segment when it is just becoming horizontal. So posterior bend of ICA here, from where this meningohypophyseal trunk arises and gives you three branches, one of them being this inferior hypophyseal artery. So this is again the view, same view. So inferior hypophyseal artery, your paraclival artery. So coming back to the lateral, we have removed the venous injection from lateral side. You can also have a look at the suprasellar things here. Or this is the opening of the dorsum sella we have here. And sometimes, arachnoid can be herniating through this opening, and we may injure during our surgeries, which can be the reason for CSF leak. So, but with tumors and all, this is the arachnoid here. Here is your opening in the dorsum. This is the sella. So this is the arachnoid. Once you remove that arachnoid, even you can see your superior hypophyseal and the branches to the stalk and suprahypophyseal arteries. So coming back, this is just showing you same dissection. So this is the lateral wall of cavernous sinus. So once you with this ICA covering most of this part, it is very difficult to access, almost impossible to access this region through endoscope. But sometime if the lesion is displacing the artery or some giving you that window, so it may be possible to go to the lateral aspect of the ICA here. So this is your stalk here now with the arachnoid covering, and if you see this artery which is coming from supraclinoid ICA is your superior hypophyseal artery. So here you can see how beautiful this this is the classical trifurcation of superior hypophyseal artery here. One may be going to hypothalamus, then two vertical branches which are supplying here and forming a plexus with the inferior branches, and this is the stalk here, pituitary stalk. So superior hypophyseal, mainly there can be multiple 5 to 7 branches, but one of them is the major branch. So coming back to the sixth nerve, this is the sixth nerve which is lateral here in the inside the compartment of the so this is the lateral wall and this is your ICA, and in between in the body of the cavernous sinus you can see sixth nerve, which is the only nerve which is inside the cavernous sinus traveling on the way to eye or superior orbital fissure. So here I'm trying to medialize ICA so we can have a better look at the structure in the lateral cavernous wall. So once you medialize it a little more, you can see how third nerve is entering. So third nerve basically coming from interpeduncular cistern, entering the border between, you can say, roof and your lateral wall. So it's entering through roof and immediately going to the top of the lateral wall of cavernous sinus and on the way to superior orbital fissure. So third nerve is here. So this is basically the oculomotor triangle, which from in the center of which this nerve enters through a cistern. Sometimes that oculomotor cistern can be extending here. So this is the third nerve. This is the sixth nerve. Fourth nerve is generally very small, difficult to dissect, but it just travels below the below the third nerve. So this is again the view, better view. So this is your third nerve, this is sixth nerve, and just lateral to sixth nerve is your V1. This is the V1 branch of the trigeminal, and the V2 it generally doesn't come into the cavernous sinus. After trifurcation at the trigeminal ganglion, it immediately goes down and goes along the foramen rotundum on the way to your pterygopalatine fossa. So if you see sometime pituitary tumor, they can extend into this area. This is the many times this is the C here, and this is the roof of the basically cavernous sinus. We are watching from below. So this is the roof, and in the roof you can see how the oculomotor nerve is entering the roof, and sometimes tumors can go here, and you may injure if you are too much dissection in this area. This is from the other side here, and now you can also see here is the supraclinoid and ophthalmic artery just below your optic nerve here. So this is again sixth nerve and petrosphenoid ligament, petros apex here. Again, this is the V2 here. So this is the ophthalmic artery again going below the optic nerve. So sometime you should know optic nerve decompression where not to injure this artery and cause problem. So here is the view of ophthalmic artery. This is the optic nerve here. So this is the dissection on both sides. You can see ophthalmic artery both sides. Now I have opened some brain area here, some subfrontal region. So these are, so once you, this is the inferior hypophyseal, now you can remove some part of your posterior clival dura to see structures of the posterior fossa. This is again the third nerve entering the oculomotor triangle. Before that, it just pierces this membrane in the posterior fossa, which is Lilliquist membrane here. This is a arachnoid fold which covers this area, which separate it from the cavernous sinus. So this is third nerve from interpeduncular and through Lilliquist going all the way to cavernous sinus. So now you can see stalk and chiasma and some this is the anterior cerebral going to suprachiasmatic area. We have PCOM going backwards, which is not injected properly here, but we can see it is going backward from arising from ICA. So circle of Willis is coming into picture now. So this is your overview of that superior hypophyseal artery, optic chiasma. This is A1 on the both the sides. Of course, ACOM will be somewhere here. So this is the PCOM going, and even you can see here anterior choroidal artery going backward here. So all the structures which are supraclinoid branches of ICA. So once you remove the this dura over the posterior fossa, you see this arachnoid beautifully covering the basilar artery. And I have tried to preserve here the branch which was supplying sixth nerve here. So this is the sixth nerve having a steep course from here. So again, coming back, same anatomy, superior hypophyseal, you have your PCOM going back here. You have your third nerve entering here. So this is the anatomy of posterior fossa. This is a sixth nerve having a steep course. This is basilar artery. Then it has been divided into this PCA segments. This is our superior cerebellar artery. Then of course this is the third nerve coming from between these two branches. So this is of course some brain we have removed here between the supraclinoid area, suprasellar area, just to show the ACOM and how they are related to, because this anatomy may be relevant, like the professor was showing our craniopharyngioma, which were going into third ventricle. So these perforators, sometimes they can be involved, some pathology may be extending. So we have to be very careful to preserve this superior hypophyseal, all these perforators going backwards. So we have this, now you can see how beautifully this anatomy, all the dissection, almost every part of the bone is out. So this is a paraclival ICA. So this is the suprasellar ICA. And we have this anterior clinoid process here. And there is a proximal ring here and the distal ring, which I showed earlier also. So between these two rings, so we have a very prominently visible this clinoid segment. So clinoid segment of ICA is much more better seen through endoscopic region rather than through microscopic, because we will be coming and seeing anterior clinoid, but not the clinoidal segment. But here you will see very prominently. So all the branches, again showing a close-up view from the posterior fossa. Then we have, of course, the petrous ICA can be drilled down. So here we have drilled petrous area. You can see this is your of course, this is a cervical ICA, then petrous ICA, paraclival, then paraclival going to your sellar, and then we have paraclinoid, and then the supraclinoid. So you can see how this whole journey of ICA through skull base, once you take out the bone and other things. So I'll just show you. This is the whole anatomy here. On one side, we have preserved the structures of this retromaxillary structure, where all the infratemporal, temporal fossa has been drilled. Even your eustachian tube has been removed on this side. This is just to give overview. Once you learn this anatomy, you understand how these structures are traveling through skull base on their way to the brain. Then you have a very nice understanding when you are operating. So now you can see how beautifully this ICA is related while traveling from extracranial to intracranial. So in between, it has a lot of bends, it has a lot of curves. So all these things, all these curves and bends are for some reason we have to understand. So this is the occipitocervical joint here. This is the foramen magnum. So this is paracervical ICA. Here it enters the carotid canal. Then it travels through the petrous bone here. And in the foramen lacerum, once we have the landmark of Vidian canal, it is paraclival ICA. Then we have parasellar ICA. Here is the proximal ring. Here is the distal ring. So this is the paraclinoid ICA. And this is, of course, the orbit here, V2 here. And this is the V3 maxillary branches of the trigeminal. Then we have the anterior cranial fossa. We have chiasmatic sulcus here. Then we have the here the cribriform and posterior ethmoidal and anterior ethmoidal. So there now that's all in its glory. All the both the ICAs, basilar artery, you have all vertebral combining here. So you so this is just to finish all the overview here. You can see the microscopic picture, petrous here, cavernous. Then we going to supraclinoid here. We are bifurcating. Here again the ACOMs are there. Then we have the MCA cut here. So this is all the journey of ICA from outside the brain to inside the brain through the skull, having all the turns and twist, so that it can, so that all the pressure changes of outside world, they are not directly transmitted to brain. There is some mechanism by the body or the nature to prevent brain from damages from a sudden variation of temperature, posture. So this is again the posterior fossa. Even you can see there is the 6-7 nerve here, 5th nerve going all the way up here, and this is the loop of the ICA causing maybe trigeminal neuralgias. So this is again, so this is the overview of all the cranial nerves. We have 12th nerve with in relation to vertebral artery here. We have 9th, 10th, 11th going into jugular fossa. We have 7th and 7th, 8th nerve complex going into internal auditory matters. We have 6th nerve going straight up. We have 5th nerve here, and this is the anterior spinal artery. So as you can understand, there is so much information in each of these slides, all these dissections, but due to some time limitation and it's already late and some power cuts, so we have to finish. Thanks a lot for attending and staying all the way to all the participants. Thank you, sir.
Thank you, Sukhdeep. This is an excellent presentation, and unfortunately, due to the power cut, your presentation was interrupted in between. But anyhow, your work is phenomenal, and I would say that it's an excellent job.
Thank you, sir. Thank
you. From the training days, we were looking at Rotan's work, and now I am proud to say that now we will be looking at Sukhdeep's. Thank you. Just there are no questions in the chat box. So just I would like to briefly, I would like you to just share your experience that by knowing this anatomy, how useful it is in performing surgery.
Yes, just many time, some time I do fiber dissection also. Many time, these dissections. So people will say, in the real world we don't see so many structures. Why do you see any fibers during your dissection? So this is a very valid question. Many time people ask why to do all this when we can do directly surgery. But once you understand this all 3D relation of these neurovascular structure, and we all know brain is the most complicated structure in the body. So once you see these fibers, their relations, once you see this internal carotid, and when you do your surgery, you start seeing this structure. I'm seeing this, behind this, there are these things. So this gives you a very different perspective to your surgical skills. I think for young neurosurgeon, it's very important to spend some time in labs. Technology may advance, some virtual labs may come, some virtual other tools may come. But what you get in the, I think, cadaver lab and in your real life experience, it really helps in your career. Thank you.
Thank you, Sukhdeep. Thank you very much. And Vernon, you can take over.
Thank you, Ketan, Dr. Ketan, for moderating the session. We had some good sessions today. And another comment I want to make is regarding the neuroanatomy. So for all students, for all young neurosurgeons, there are two times when you see and review anatomy. First is before you start your tumor surgery or whatever brain surgery you're doing. And the second is once you are finished with the surgery, you have to appreciate the anatomy and you have to appreciate what you have left behind, how you have preserved the anatomy. If you do not see anatomy at the end of the surgery, then either the patient is in problems or you have not done good surgery. So that is my advice. So in a good way, we have been able to start with anatomy and end with neuroanatomy. So I would like to invite Professor Goel. He's in the attendees panel. So I think they're trying to get into this panel. Could we unmute Professor Goel, please? If he could give us some closing comments before I can start with our moderators. Can we get Professor Goel?
Yes, sir. Sir, we have. Yeah, he's unmuted. Hello.
Hello. Can you hear us?
Yes, sir. We can hear you, sir.
Okay, if he cannot be connected, then I think I will move to Dr. Devpujari, Professor Devpujari. Your closing comments, please. Once he is unmuted.
I think, Vernon, thanks. It has been an excellent idea to get our young teachers and, for students, I think it is really a feast. And I hope this series continues. I would just like to remind the young neurosurgeons also the fact that NSI is doing an anatomy webinar series, as you are aware, with the Spanish group, and these will be on Saturday afternoons. So please join us during that time. And Vernon will tell us about our next program very soon. But thanks, Vernon, and thanks, Baxter, for supporting the activity.
Professor Deepak Gupta. Is Deepak there?
No, sir.
Yes, sir.
Yeah.
Yeah, I'm there.
Yeah, please go ahead.
No, I'm good. I mean, I think it was an excellent, short and crisp half-a-day conference, and it was. Am I audible?
Yes, sir.
Yeah. It was more like a half-day conference, and from neuroscience, epilepsy, and
Breaking.
hello.
Yeah, better.
I'm good. I mean, we had a good half-day webinar conference. I would say, Dr. Vernon, it was a great initiative, and I thoroughly enjoyed it. No comments further from my end.
Thank you. Now call upon Professor Turel, Sheki Turel.
I think Vernon, maybe we have to look at the time as well. So
Yes.
that is something we'll have to probably have a tight control.
Yeah,
Vernon,
but issue
Vernon,
is
just
the net is the problem. That is the issue.
yeah, Vernon, just one thing I just would like to tell the junior
Yeah, okay,
colleagues.
you go ahead. Suresh, you go
Yeah,
ahead.
yeah. Such a wonderful program, such a nice presentations, and this education program that you have started. I think will continue with this from time to time, and have more better presentations every time.
Thank you.
What is really very remarkably absent was the questions. We didn't have many questions from the juniors. Unfortunately, I don't know whether it was just a communication problem or something else, a net problem or something. But I thought we should have more and more questions coming from the juniors. So next time maybe we will stress on this point.
Yes.
Okay. Thanks a lot. Overall, very good.
Yeah, I think is Professor Turel there? Professor Matthew Abraham. Is Matthew around?
Most
I
people
left,
have
I
left.
think, because
Okay.
it's 3 o'clock now. Yeah.
What about? Yeah, I know it is crossed more than 1.5 hours. So what about Professor Goel? Can you connect him?
Yes, sir. He's unmuted, but I don't know. He's already unmuted.
Yeah, but we cannot. Goel, can you hear us? Okay, if it is not possible to be connected, then I will just take a short review from our speakers. Thank you for your wonderful talk. My personal thanks, and I hope the residents really benefited from this. And we shall start with Dr. Sukhdeep. Is Dr. Sukhdeep?
Yes, sir, of course. I think it was a very well attended half-day conference, and till end, I think most of the participants stayed. I think they must have learned a lot, and as sir said, we expect maybe from next time more questions are asked. Thanks for all the effort. Thanks, sir.
Yeah. Thank you. Dr. Chandan? Unmute, Dr. Chandan, please.
Yes, sir. Unmuted.
Yeah, please go ahead.
So this was an excellent overview for all the exam going students of various topics. I think it was the talks were very well selected and very well presented. And yes, the only thing, as Sankla sir had pointed out, maybe if we had more questions and answers, then it would have made it much more useful for the final year students, exam going students. But thank you very much to Vello sir and the Baxter team for this.
Thank you. So Rushikesh?
Yes, sir. He's unmuted.
Yeah, unmute Rushikesh, please.
So he's already unmuted, sir.
Yeah, but he's not there.
He's right, sir. He's there, sir.
Okay, can you go ahead to Dr. Prakash?
Yes.
think this was a very good initiative. I think to listen to all the other speakers, I had very informative talks from Dr. Sukhdeep, Dr. Chandan, Dr. Rishikesh, Dr. Mazda, and Dinesh. So not just the responsibility of speaking, but also the pleasure of learning from all the others. And yes, I think questions would have been welcome. I think if somebody does want to get in touch with us personally, I think if email IDs are made available, they can definitely ask us questions on email. Thank you for all the thank you for the initiative, Dr. Vernon, and thanks for the invitation. And
Thank you. Yeah, Dr. Mazda.
Yes, I just want to echo his sentiments. I think I learned a lot more than I think I could have delivered. In that terms, it was a great learning experience for us. I'm sure it would have been as well for the residents. So I'm just grateful and thankful to be part of this.
Okay. Dr. Jayesh.
Sir, just I would like to emphasize on mainly two things. One is especially the concept. The concept was excellent. It was just to teach the students and youngs, and we also learn many things from our colleague and senior person. So it's not a one-man show kind of thing, but it's kind of the teaching program. And second thing is, sir, it was very we feel honored that we have so much who's who of a moderator or senior people like you and all the panelists. And when in front of them, as a young neurosurgeon, we present something, and if they applaud, and that would definitely build up our confidence as a young neurosurgeon. So that was an excellent idea.
Thank you.
Thank you so much. Thank you so much.
I think I can't.
Sir, Dr. Rishikesh is here.
Yeah, call him.
Yeah, he's there. Rishikesh, sir, we can't hear you. Hello? Hello?
Okay, I think it's connected or they have left. Anyway, thanks. And I would hand over to Ajay now to do the closing for today's webinar, which has gone almost 1.5 hours your time, and you must be hungry. So over to you.
Thank you, sir.
I think we have been a little over-ambitious.
I will not take much time, sir. I would like to say thanks to Dr. Velho and the association, MCNS, for giving us the opportunity. I would like to also say thanks to all the eminent moderators for their presence and their expert comments. Again, I would also say thanks to the speakers for their wonderful presentation, and I'm sure it has been a learning experience for all of us as well as participants. And at the last, thanks participants for being there. I think it has been a great academic feat. With that, I would like to close and would like to assure you also in the future our continuous support. Thank you, sir.
Thank you. And special thanks to Ganesh, Abhishek, Sachin, and the IT team for doing a good job, because I'm more comfortable with the WebEx. I don't know why, because I think the videos are much better seen on the WebEx rather than Zoom. So thank you all moderators, thank you speakers, and have a good evening. And thanks to all the participants. And we'll be doing this with a 2-week gap so that the students can go back and read, relax for some time, and then go back and read. And it does not become too toxic if we have it every week. So it will be a 2-week gap, and then we'll have the next session. Thank you all.
Should be some lunch with your program.
Sorry? Yeah, it should not. I think that's why we keep that Sunday morning 10:30 to 1:30, which Dr. Dev Pujari suggested. 1:30 is good, but we are already at 3 p.m. now. So anyway, have a good evening and enjoy the rest of the Sunday. Thank you. Bye.
Thank you.
Thank you.